So welcome to PerfWeb 32, day 2. And, oh, it's my phone. What are we going to do? Darcy, why did you turn the volume up on my phone? Okay, there you go. And I want to thank our sponsors, LivaNova and Siemens Diagnostics, for their support. We genuinely appreciate it. Please click their links and take a look at the various different products and services that they have. They're very heavily involved, of course, in cardiovascular intensive care medicine. We all know them for a variety of reasons. Before I get started with the introductions, however, I'd like to ask all of you to do me a favor, please. And that is, if you're watching on YouTube or Facebook or Twitter or LinkedIn, please do one of the following. Like us, share us, follow us, and of course, you're welcome to chat on YouTube. That's the one that I monitor, although you can do it on Facebook and Twitter. And I think Darcy's going to be paying attention to that a little bit today. But most importantly is please click the subscribe button. So you have to subscribe. We're growing in subscribers, and we really need to keep pushing this. I want to get 700 more before the end of the weekend. I don't think it's going to happen unless you really do this, but I'm really counting on you, okay? I appreciate it. So give us the thumbs up as well. Also, go to perfusioneducation.com and leave us a testimonial if you'd like to. It would really be appreciated. And if you would like to be a presenter on our program and join what has really become a very robust faculty, and you'll see that scrolling here, we just keep adding it to it, and you're going to see 2 new faculty today that I think you're going to find very, very, very interesting. These are true content experts bringing you the very best in your continuing education needs. We're going to skip the Slido today for today's program, but when you see this animation, then that will mean that the phone lines are open. You're welcome to call in and be live on the air and ask a question. We'd really prefer that you do it that way, but if you're driving, please be careful. Now, let's get on with the introduction. So, you all already know Tammy. Tammy Sparacino, perfusionist for about 20 years, came out of Texas Heart Institute. She's been on many programs, so welcome back, and thank you so much for doing these programs with us all of the time. I appreciate it so much. I want to jump right over, skip the next person, and go to Dr. Samir. We all know Dr. Samir. Dr. Samir, of course, is double boarded in intensive care medicine and anesthesiology. He specializes in mechanical circulatory support and pulmonary support, ECMO, if you will. But he's also an expert in telemedicine and is very, very strong, very involved in the tele-ICU. Very important, but we all know Dr. Samir. He's been here several times, so welcome back, Dr. Samir, and thank you very much for making it here today, albeit late. And then next to Tammy is Dr. Soma Jothula. The Y is silent. He is a pulmonary and critical care medicine doctor. He earned his medical degree at All India Institute of Medical Sciences, has completed his internship and residency in internal medicine at Drexel University up in Philadelphia. I used to work at HUP, as a matter of fact. Did you know Dr. Stevenson, Larry Stevenson? Did you know, let's see, did you know Clark Hargrove? Did you know any of the heart guys? You might not have known the heart guys, yeah.
Residency, actually.
Yeah, but he completed your fellowship in pulmonary and critical care medicine down here at Baylor College of Medicine in Houston. You're board certified in internal medicine, pulmonary medicine, critical care medicine. Has been practicing medicine since 2006. His clinical interests include lung transplantation, interstitial lung disease, COPD, pulmonary hypertension, and interventional pulmonology. You obviously are very involved in a lot of ECMO patients with that type of especially the lung transplantation. And of course, I'm sure you see a lot of ARDS as well. Your practice philosophy is to provide the highest quality of comprehensive and innovative care to patients with chronic lung disease. You believe that it is you believe in a personalized approach, I should say, to managing each patient's medical needs. Dr. Jothula is the medical director of the Lung Transplant Center at Memorial Hermann, Texas Medical Center, very big place, and part of the clinical faculty as an associate professor at the McGovern Medical School at UT Health. You're a member of the American College of Chest Physicians, American Thoracic Society, American Society of Transplantation, and the International Society of Heart and Lung Transplantation. You are a resident here in Houston, obviously, with that kind of a practice, and you are married with 2 children, and in your spare time, you enjoy clay shooting, that's scary, running, and has aspirations. I mean, really, pulmonologists and clay shooting just don't match. And you have aspirations to be a writer.
That's right.
Now, that's very interesting. I want to hear more about that. Tell me about your, huh?
I don't know, it's something I've started actually, I think probably had interest since high school. I do write poetry actually, less of prose and more of poetry.
Oh, wow.
Really?
Maybe we'll share someday, dude.
Maybe so.
Yes, I probably need some of that. I need it. Believe me, it might calm me down. I don't know. So, tell me, like, what kind of genre of poetry is it?
Are you going to write novels?
Inspirational? Is it dark? Is it sci-fi? Is it medicine? What do you write? What do you like?
I think it's more inspirational, I guess, more about my thoughts and my personal journey. So more about that, and probably I don't know how to phrase it actually. I went through some challenges. Obviously, what I say myself, midlife crisis, and one of the tools I found to get over that phase was essentially writing what I feel or what it is it should be.
Very good. Well, that's really excellent. That's really interesting.
That's right.
You know, I think a lot of people, they, especially with the kind of jobs that we have, and you know, the demands on our lives just from work, always assume that that's all we ever do, that we don't have these outside interests.
That's
I
right.
think it's really interesting. I'm glad we talked about this because it's important for people to humanize
Absolutely.
healthcare professionals, educators, it doesn't, you know, whomever it may be, even the nurse at the bedside who is taking care of the patient and the families and those interactions. So many times the families, they assume that, and of course they're in crisis, their family member's very sick, this is especially in the ICU, they just assume that is our life, that
Absolutely.
we just 24/7, we only do this and we have no personal life at all.
That's true. That's true. Yeah, absolutely. I mean, that's one of the biggest challenges. I have realized it. You can read about it. You have seminars and everything else, but unless you go through it personally, you never understand that.
Absolutely.
As you know, the training which we all do, I'm sure you guys all have been the same. We all have aspirations, so we need to do this. And at some point of time, your professional life pretty much encompasses everything that you are.
Absolutely.
And when you struggle, that becomes a real challenge. Hey, what do I do other than that? And it's been very fascinating in that way, actually. It gave me a lot of time to reflect. And I realized actually submitting poetry, I wrote a poem regarding a patient encounter. It's more tough than any JM, actually, to be honest, to publish poetry. But it's very cathartic, and actually I shared it with the patient's husband, and it was very phenomenal, actually. And
I'd like to know more about that. We need to explore that a lot deeper,
Absolutely.
but it's really refreshing to hear all of that. And I appreciate you being here so very much.
Gotcha.
Now, before we get started with your first presentation, let me move down to Tracy Nicole Howarth. I can say it right this time. You are a LB licensed
Baccalaureate
social worker.
Yes.
That's right. That's what the B stands for. I was really messed that one up. But you graduated from the University of Texas in Austin.
Yep.
So you do that horn thing?
I do.
Yeah,
Yep.
okay. You have a Bachelor of Science degree in Child Development and Family Relations. You went on to
Yes.
complete all courses and requirements, earning her state of Texas licensed baccalaureate social worker credentials in 2003. So you've been at it for about 17 years. You don't look old enough to have been able to do all of that, but okay. You began your career as a child abuse investigator, interestingly enough, for the Texas Department of Protective and Regulatory Services. And you worked as an advocate for abused and neglected children before transferring to an inpatient psychiatric center, working with children and youth with severe mental health issues. I was one of those kids, and the system failed me miserably. That's how I ended up here. In 1992, you began working with Harris County Community Youth Services, where you worked tirelessly as a crisis intervention specialist, and I'm sure that's tragic when you're dealing with kids in crisis. It's probably pretty scary. And you're a liaison with multiple schools, child protective services, and police agencies, juvenile probation. You've worked on anti-suicide and homicidal threats, children that are victimized with internet crime. So a lot of things like that. But what brings you here today is you were introduced to me by Michelle Berdovsky, who is a administrative level educator at a school here in Houston. And she was telling me that you had come in and talked about the vaping crisis in these schools.
Yes.
And I think for everybody out there that's watching the program today that has children, this is something that we are all, well, you have a daughter, I mean, and now your daughter's going to college now, I guess. She's a little older, but when she was 15, 16, you might not have had the vaping thing to be concerned about, but I don't know what ages your children are, but you know, if you have children that are 15, 16, 13, 14,
Right.
at this point in time, this is a big problem because you've seen on the news, this conference today was actually the brainchild of Dr. Samir. I have to give him credit for this. He said he wanted this to be our best conference of the year. So we're tackling a very timely, I think, and very frightening topic for a lot of parents, and that is lung injury associated with vaping. And what you're going to do, Tracy, is tie it together with how pervasive this really is. And then we're going to be going into ECMO and Dr. Samir and eventually Dr. Matoyer. We should have gotten that poster, that thing, you know, that they put on the stick with his face and put it over there in the corner. He's a heart surgeon, though, so he'll be the latest. It starts off pulmonologist, then anesthesiologist, and then heart surgeon. That's the evolution of how they arrive, right?
Yes, it is.
Pretty typical, I think, for all of us. But anyway, with that said, welcome. Thank you very much for being here, and I appreciate
Thank
so
you.
much you giving the presentation and involved in the conversation that you're going to be today. So, without any further ado, I think I've covered everything that I need to cover. Why don't we go ahead and load Dr. Soma's talk up, and let's go ahead and get started with our first lecture. And everybody out there, thank you for joining us this morning. We really appreciate it. And everybody in our studio audience as well, thank you all for being here as well. So, Dr. Soma, the floor is yours.
Thank you very much. I guess all the attention comes to me. First of all, I would like to thank everybody actually for giving an opportunity to actually give me a chance to look more into it and see what exactly is going on. So, as you know, the topic is vaping-associated lung injury. I'm a big New York Times guy. Please, I know I'm in the wrong place to say that, but so this was a news which came out somewhere in mid-August, actually, in New York Times. Dozens of young people hospitalized for breathing and lung problems after vaping. Probably, I think this was one of the times when everybody picked it up, went on to major networks after that, and there was a whole explosion of identification regarding vaping and the different lung injuries which happened with it. Started off in predominantly in Wisconsin and Illinois, and I think this was around 20 patients or so. And subsequent to that, we know in the last probably 6 to 8 months, there's been a lot more identification of different problems and people suffering from it. So one of the most fascinating things, actually, even I came to US when it was in 2003. I don't think we had e-cigarettes at that point of time. I think somewhere around 2007 or 8 or something really started coming in. I think Juul came in 2007. I may be wrong on the date, but somewhere around that range. This is a very interesting graph. As you can look at it, it's nice to know what the prevalence is, but it's also scary. Because this is among all the high school kids and middle school kids. If you look at the graph on the left side, from like 2011, nearly 0% use of e-cigarettes. And to now, it actually goes around 20% or more. Pretty much 1 in 5 high school kid has used e-cigarettes maybe in the last 60 days or 90 days. And that goes across the board. If you look at the data, actually, we are in a very historical trend in the sense tobacco consumption has actually, probably this is the lowest it has been in the last probably 50 years or so in the United States. But on the other hand, use of e-cigarettes or any of these other products which are considered as an alternative, it has really, really gone up, and it's more in the youth. And that's the most scary part. It's not the adults who are using it, it's actually more in high schools and adolescents and young adults who are using this more and more. What led to it? Obviously, pervasive marketing. I'm sure all of you guys have walked into gas stations. Before, it used to be a whole section on Marlboro and different things. Now we have Juul and all this very eye-catching ads about it. I did not know, like, at the different options, you have flavors and things and all of those. The putative safety, this was initially was a good thought that it may be a better alternative to use nicotine rather than smoke tobacco products. And that was one of the biggest selling points. And even I think, even though maybe explicitly it wasn't marketed that way, but there was a subtle between the lines message, hey, this is probably more healthier option than smoking. And obviously when we are all teenagers, we know we are very excited to do all sorts of stupid things, sometimes even as adults. But I think that's how it picked up. Considered an abstinence strategy. It's so funny, in Feb of 2019, NEJM published a study which came from NHS in UK, where they actually looked at e-cigarettes as an abstinence strategy from tobacco smoking. And as you can imagine, it was considered to be safe. And this was published literally a few months before the first paper came out about vaping-associated lung injury. So as you can imagine, even in UK, even to this current date, it's considered as a safe strategy, even though in the United States there's a lot of swing to the other side to actually abstain from everything. The ease of manufacturing, a lot of illicit production, and that's what is considered the risk, or people who developed it, because of all different kind of additives which have been added, which may not be exactly legal. And obviously it has developed into a delivery device, not just limited to nicotine. You have THC, cannabidiol, butane hash products, and different kinds of stuff. So it became a softer way of using marijuana too, and as you know, legalization, and this was considered one of the alternatives for that too. And now, if you look at it, it's the most common tobacco product which is used among youth in United States, which is a very concerning factor. Somewhere around June or July, the Wisconsin State Health Department essentially started surveilling cases where they had unexplained respiratory illnesses and what were the ED visits. So as you can see, from Jan, and when you go into July and August, there was this spike, especially in male patients, even in female patients, where the respiratory illness could not be explained by the usual causes like pneumonia or anything of that sort. And the whole identification of the epidemic, as you can see, was led by some physician. He had an ER patient whom he actually reported to the Wisconsin State Department, and that's when the whole investigation started. Both Illinois came in and then Wisconsin came in, and people started investigating what is this different unexplained respiratory illnesses which we are finding, and predominantly in younger adults, and that to males. And that's what led to the diagnosis. So this is the surveillance criteria which people came up with along with CDC. So any use of e-cigarette vaping in the last 90 days from symptom onset, which is usually respiratory symptoms like cough, hemoptysis, we're going to talk about that later on, and obviously having an abnormal chest x-ray or a CAT scan. And you want to rule out the usual culprits. Pneumonia is the most common thing, can be viral infection. We are currently in the winter phase, so influenza, very common. Other kinds, Streptococcus, Legionella, things like that. And obviously there is no other evidence of any other alternative plausible diagnosis like rheumatological process, lupus or things like that, or a cancer, or is it heart failure. So when you fit into this, then epidemiologically you're considered a case of e-cigarette or vaping-associated lung injury. That's what you call a confirmed case. And there is something defined as a probable case. This is the criteria which we use. In this, you identify an infection, but it's not considered the sole cause of all the respiratory complaints. So that's what is considered a probable case. Again, this has been developed as a ease so that patients or healthcare providers can report, and we can actually monitor across the country who are the people who are developing it. So hopefully better identification, treatments, and prevention down the lane. This is a paper which got published in September, around 53 patients, both from Wisconsin and Illinois. So probably gives the best idea of what were the cases which we were seeing. As you can see, the median age was 19. These were very young people, and ranges anywhere from 16 to 53. predominantly male, Caucasian, probably depending on the cases which were identified and things like that. And almost 1/3 of the patients had some sort of asthma or anxiety disorder or mood disorder documented on their medical record. And this is the most fascinating thing which I found. Almost 61% of them said that they used some sort of nicotine product in the last 90 days. THC use was almost 80%, and the combination was around 44%. Scary, but that was the index case cohort series, and obviously that's what they found in it. The median duration of symptoms before they came to the ER or any healthcare facility where it was identified was around 6 days, so pretty rapid acute onset of symptoms. All of them had some sort of respiratory illness complaints, as you can see, shortness of breath, almost 87% of them, chest pain, pleuritic chest pain, cough in 80% of the patients, and around 10% of them actually were coughing up blood. They had hemoptysis. So pretty serious. Initial radiological findings when they did x-rays, obviously everybody gets an x-ray as you land up with some sort of respiratory complaints to the ER or something, 91% of them. The way I tell people is if you can identify something in x-ray, that usually means it is pretty significant, because x-ray, the fidelity of the picture is so low that you really had to have a very major defect going on into it. And obviously 100% of the patients had abnormalities on the CT chest, and bilateral infiltrates across the board, every one of them had it. 94% of the patients were hospitalized, and a lot of them actually had some sort of ED visit or went to their primary care physician, almost 70% of them, before they got hospitalized. So probably started off as some sort of cold or something, and they thought maybe they had it, went to the ER doctor. And usually, as you know, I'm a pulmonologist, the two things which I always give to people if I don't understand anything, antibiotics and steroids. So there you go. So probably that's what they received majority of the times, and obviously symptoms did not improve, and they went on and got hospitalized from it. The median duration, thank God, was only 6 days. The maximum, as you can see, the range was 25 days. Pretty much majority of them required some sort of supplemental oxygen. And the rate of mechanical ventilation is 32%, so that itself tells you that the injury was really severe. Acute onset, severe acute respiratory failure. That's what majority of the people who were in this cohort faced, and obviously a lot of them got admitted to the ICU. If you're on a non-invasive ventilation or mechanical ventilation, that's where you go on to. And one person in this cohort actually passed away from the primary illness. Again, shows you the severity of the illness and what we are talking about. These are the x-rays actually from the same paper. As you can see, probably the projection is not so great, but on both the sides bilaterally you can see opacities, and you look at the CT, the normal lung has been pretty much replaced by some sort of profound inflammation. That's pretty scary, and there's actually, even in the rest of the normal lung, what we call ground glass pattern, which again shows some sort of alveolar filling process which is going on. I'm sure Dr. Hani must have seen it. This is what we classically see in patients with ARDS. This is how they land up with. Again, it shows the severity of the lung injury, and that's what.
How long do you think it takes for this to happen?
That's a very interesting. That's what I was looking at this thing. The median duration to onset of symptoms was, they say, 6 days. So probably it's a very acute origin of symptoms, essentially. So whenever the inhalation injury was, it just went on. Within a week, they started having all this.
So do you recommend getting a high-res chest CT?
That's a very good question. If you are able to pick it up on an X-ray, using a due diligence, I think you should be able to diagnose it. Again, the whole epidemiological diagnostic criteria and things like that were derived for ease of reporting, may not be actually medically prudent. The usual thing, if I see a patient who walks in, 20-year-old, has bilateral infiltrates, complaints of cough and shortness of breath, my first impression still, common things are common. Is it an influenza? Is it a pneumonia? Does he have streptococcal pneumonia? Things like that. I think that would be still my way of addressing it. What I think about e-cigarette associated lung injury, that would be something what I will call a diagnosis of exclusion. That's where I would go to. Regarding a high rise, do I need it on everybody? If somebody has a normal x-ray and still have profound complaints or hypoxia or something, that's probably at the time when we should delve into more CT or a better diagnostic technique. I think that's the way I would approach it.
Has there been any role for lung biopsy in this situation?
We're going to talk about it. Actually, there's some pathology slides which came in, and even if you look at the correspondence or whatever the others who presented it and everything else. Would I do an open lung biopsy? Because the other hat I wear is I do a lot of interstitial lung disease. We do open lung biopsies when we are not sure what exactly we are dealing with. Where one, the diagnostic certainty, so you can actually prognosticate it and then talk about therapeutic options. Would I go for an open lung biopsy in this scenario, somebody who has such a rapid, acute onset of severe respiratory illness? Then it's a risk and a benefit, because even doing an open lung biopsy, as you know, is not a simple procedure. You have to have a single lung ventilation, put in a, open up the
ECMO
chest.
backup.
Yeah, ECMO backup and things. So you may cause more harm than benefit, unless you're absolutely sure, hey, that's going to change how the patient is going to behave, or open up my options regarding doing therapies which can potentially change the course of the illness.
Well, let me ask you a little controversial question. Would you need a biopsy before you list them for a lung transplant? See a controversy.
It's,
Put you on the spot.
Oh yes, as a transplant pulmonologist, that's a very a challenging question. So because transplantation, just let's talk about the medical aspect of it. When do we try to transplant a patient? So one, we know realistically or with the known clinical knowledge, the disease is very severe. It's potentially life-threatening in the next 12 months or so. We have maximized all the therapeutic options which we have, and that's the only way I can prolong a person's life. And now on the other side of it, it has happened because of some sort of illicit use of something, which brings in a whole different, it's a whole can of worms regarding compliance, how are they going to do, and things like that. Would I just go and pop in and open up a chest of somebody and say, let's take the lungs out? Probably not. It's a very precious resource, and obviously that's the reason why we have medical review boards and everything else. So it's not biased by the primary team which is taking care of the patient, but as a group thing, are we actually doing the maximal benefit of this precious resource and offering it to the appropriate patient? Yes, have patients undergone a transplant? I think there was somebody in November or December who actually underwent a bilateral lung transplant. But if you look at the paper,
I think.
yeah, they had a prolonged course. Obviously, they waited 2-3 months, if I remember it right. And then they realized, you know what, it's not improving, which is pretty much like a post-inflammatory fibrosis, which we have seen in the past back in Methodist Hospital. That's case, yes, absolutely, I think we should be able to go for that. But would I do it at this stage? Probably
Would you need
not.
a biopsy to go for the list? Or you got to go on diagnostic, like general diagnostic criteria?
Just general diagnostic criteria would be my clinical call to make. Because I'm very cautious, open lung biopsy, especially, we have done it. If you have bad, even IPF flare-ups, people come in with it. The way I tell patients, it's very simple speak, like when we evaluate for transplant, hey, even if some reason you landed up in a Nazi camp and some crazy doctor decided to take one lung away from you, even then you should be able to breathe room air and maintain your oxygenation. The fact by breathing room air you're still hypoxic tells you there is a significant severe diffusion impairment. Now you reach the state where you're breathing in 50%, 100% pure oxygen, still hypoxic. Would I drop one lung and do a surgery? Probably I don't think it would be a prudent medical choice at that point of time.
And we are not being involved in lung biopsies, which ended up in like a disaster ECMO. Yeah. So
Yes.
we definitely don't want to go down that route.
Yes.
Would you guys say, if I can ask, I mean, that heart looks dilated to me.
That's a portable picture, so we have to take a little grain of
Take a
salt.
grain of salt.
It's because it's shot from the front, so since the heart is closer, so it will appear bigger compared to a PA lateral where it's coming from the back. Yes. Younger patients, again, at least in this, they did not report patients had any sort of cardiac issues. But again, even on the diagnosis, they say it should not be related to a heart. But if we have an elderly patient, some reason he had an MI or something, or baseline heart failure on top, used e-cigarette and developed it, probably, yeah, that's going to be a very diagnostic and therapeutic challenge.
But this is a young patient.
These
Shouldn't have
are
any
younger
cardiac
patients,
involvement.
yes. So we would assume that they have really good cardiac function.
Very good.
All right, great.
Okay.
Let's go. So what I was trying to show on this biopsy, this is what you call a lipid-laden macrophages, and there's a lot of vacuolization. In simple terms, if you inhale oil of any sort at a huge amounts, back in the day we used to see it, people used to inhale, use castor oil and they would aspirate it. That's something which you see in plastic textbooks back in the day. That's the sort of pattern which you see very similar to it. So the concern was people were using marijuana-laden cartridges which were loaded with vitamin E oil. I still, It befuddles me. Why would anybody
Vitamin
put
E is
in
good for you, right?
I don't know, maybe not exactly inhaling.
Maybe not in your lungs. Yeah.
So that was one of the hypotheses which was there, was probably the additives which were used, which actually led to the injury. Again, the same thing. That lung is pretty much grossly injured, and that's what we know about the pathology of it. Again, shows you this, and all this inflammation is happening around the airways, so which tells you that whatever it is, you have inhaled it, and that's the reason why the lungs are getting damaged. So the management, is there any steadfast treatment as of right now? No. Supportive care. Majority of the patients, obviously, some sort of oxygen support, because if you pass away, that's because of it. You don't have enough oxygen supply. So non-invasive or invasive ventilation, ECMO support. I've heard offhand, even I went to San Antonio recently, actually, to one of their other hospitals. They started a huge ECMO program, almost, they have like 40% VV ECMO runs. And they were telling me they saw a case in 2016, which now they retrospectively look back, a young guy, 22-year-old, came in unexplained ARDS, they thought, and went on a whole full-blown VV ECMO support, and found out later on it was all e-cigarette related. Wow. Yeah, apparently he smoked marijuana at some party for the first time, and within 3 days or something later on landed in the hospital.
Oh my God.
So very fascinating, that too in Texas. Obviously, transplantation, there have been reports. Obviously, there's been one so far where a patient, unfortunately, the lungs did not recover back to some reasonable shape and size that he can lead a normal life, so which led to undergoing a bilateral lung transplantation. Again, other facet, all the nosocomial complications, I'm sure you guys must have known. It's not as simple as putting a cannula or putting a tube down somebody's throat and let's think everything is going to be fine in the ICU. Then all the downstream effects which come from it. Nutrition, different interventions, bloodstream infections, UTIs, bed sores, and then the whole 9 yards. Obviously, what we call the inertia of motion. Once the ball starts rolling, then you start picking up all sorts of different things on the way. And essentially good ICU care, I think that's where the whole thing should come out. And this is the latest, I think the last one I looked at it, almost 1,000 or more cases, CDC says, which have been recognized so far. It is raising. There was actually an article last week in New York Times again, which says there is no decrease in the incidence. So the numbers are still continuing to be high with vaping-associated lung injury. 19 deaths have been confirmed so far. So that's where we are. It is a serious illness. It is a crisis we are facing. Why now? Why not in 2007? Nobody has an answer as of right now. So different things have been put forth. Obviously, the best thing is not to use any products. The government has actually pitched in some of the states. I think New Jersey has actually banned all flavored products because that was a big catch for youth, using mint flavored and God knows what else, different flavors, strawberry and things like that. So no more flavored products are going to be sold. The smoking age, even both for cigarettes and buying any sort of e-cigarette, is 21 years now, which is probably a good thing. So hopefully we'll see a downtrend in all that age group we saw in high school kids and things like that. So that will go down. Limiting access, I think there is a, if I remember it right, President Trump signed it, you cannot market it openly, or FDA has actually said that you cannot put in openly in a display or something of that sort. So that's probably a good thing too, rather than seeing all the fancy ads. All of us have done it. We walk down into HEB or we're walking down the aisle and they have all these catchy things. For me, Snickers bar. So you always think, oh, today is the day I'm going to die. Invariably, you pick up a Snickers bar. So things like that. So
absolutely.
Yeah.
And look at the fancy commercials. They're so happy.
Yes.
They're vaping and so excited. Different flavors. Nobody's showing somebody on a ventilator or somebody in the ICU or somebody on ECMO.
And if you're a guy, girls like you more.
Absolutely.
There you go.
You're going to attract more girls.
You always get
Why
the pretty
not?
girl.
Yeah.
It's like the Marlboro Man we used to have.
Exactly.
And nobody tells you died from lung cancer. But and obviously education, both from, I think the at-risk group, as we have identified, is those high school kids. I think that's where it starts off. I think that's the key part of it, essentially, is to prevent that. Hopefully,
Elementary and junior high.
yeah.
Coming elementary and junior high. I don't think there's I mean, do they need that? I'm not sure when you go by, do you need to show like a driver's license or anything? I don't think so.
I think with the 21 years
It depends on
now.
the shop. It depends on the shops that don't care and don't card. You can get it, but I'm going to talk to them about how these kids are actually getting their hands on it, because it's pretty frightening how easy it is for them to get it.
That's true. And yeah, that's where the limited access to it probably will play a big key role into it. It's actually a shame, the controversy as a physician, which we will look at. I know smoking is a lot more injurious, no doubt about it, but where do we find the balance? Because as of right now, as of at least until mid of last year, the trend towards why e-cigarettes were encouraged by at least a certain part of the medical community was, okay, it's a lesser evil compared to the other one. Should we even say the same thing now? I don't know, actually, to be honest. Like if you look at UK, even in Jan, they said NHS says it's okay to use e-cigarettes. So
Let me ask you more controversy. So what do you think? Maybe we should legalize THC and then will be an issue, no issue? And you know, other people say that vaping now that was supposed to be safer
That's
is causing injury. Should we legalize THC? And you know, there's some states who have it legalized. So
we are humans at the end of the day. We all have our addictions. If you look at the other aspect, alcohol. Every day, 6 people die from alcohol-related injury in the United States. Something which is pervasive. We talk about having a wine in Thanksgiving, Christmas. It's such a socially acceptable thing. And imagine that's in the United States. You have 6 to 7 people dying from alcohol injury. So again, what I'm not trying to say, is, yes, can we ban everything and live in a puritanical society? Probably not. But I think it's more about education, limiting the access and not getting into addictive behaviors. I think that's the key. There will always be people. Everybody is different. If God created all the same, we would all look the same. Obviously not. So I think identifying the at-risk population and preventing them from catching it, I think that's probably a better strategy. But again, I don't know
I think
what the right,
also
wrong
people
answer.
need to be informed what they're signing up for.
That's right.
Did they know what
Exactly.
e-cigarettes is all about? I think you need to be informed.
That goes back to the education.
It does.
That they really need to understand the risk that they're taking and that it's not safe. People think, especially young people think, if it's being sold, it must be safe. Someone has checked it out. We know what's in there. We know what it can do to us.
Absolutely.
No,
Are
they're
you- are
convinced
you-
they're convinced it's benign.
Right.
They're convinced it's actually like not harmful at all, not like what it could do to you. They're confident it can do nothing to you.
Exactly.
That's right.
They have no idea what chemicals and additives
Exactly.
and toxins are in a vape pen.
That's right.
They're not educated about it, and it's a social trend, and you're not cool if you don't do it.
It's big business.
It's huge business.
It's again, Juul was bought out by the tobacco company. Big Tobacco bought out Juul because
Absolutely.
it's a multi-billion-dollar industry, and obviously, money plays a big role.
And there's no regulation. FDA is not looking. I mean, there's
That's
no
right.
regulation. Everybody's doing their own thing. And I just learned like about CBD. I'm gonna use that example. CBD, different percentage of THC. You buy CBD from Colorado, much higher than here.
Yes.
So really, nobody's informed and well informed, and there's not much education. People say, "Oh, CBD is safe. You're not gonna lose your job. It's gonna take your pain away." Then all of a sudden you're fired because your THC
Right.
level is so high.
That's right.
Right.
Or you're off the transplant list because your THC is so high.
Absolutely.
So these are the kind of things people need to know about. That's the program I'm signing up to. I'm signing up to have e-cigarettes, and this was might happen. Just be an informed patient or an informed participant.
Absolutely. I mean, there are really viable examples of it. Look at the opioid crisis.
Right.
If you look at the original ads in 1991, it was so driven by the industry that we needed to control pain. And we landed up using this stronger and stronger opioids. And we have reached a stage where the number one, people did not die from overdose from illicit drugs. It was not cocaine which was killing people. It was not heroin. It was prescription opioids. Means in the span of 2 decades, we reached a state. Now we have swung all the way around. Like if I want to prescribe more than 7 days, I need to look up, have they taken anything in the last 12 months, really counsel on them and everything else. But how did we reach that stage? Again, it's the same thing as a group. I guess it starts right from high school, and everybody should be involved in it. Even as a medical professionals, I think that's what we should be very cautious where we are heading. It's very catchy when you have nice ads about OxyContin and everything else, and you have this nice lady. There was a big documentary on it. Oh, my life is so happy, my pain is so free. And later on, you look at it, they all got addicted to it. And it's dangerous. And
You know, I'm going to be a
that's
bad
what
boy,
we are heading.
Jatola, and say also part of it, and the nurses here will know, it was CMS when they had the smiley and the frowny
yes.
face.
Oh, yeah.
And the patient had to have my smiley or frowny. And you know, the HCAP scores were based on smiling, not frowning.
Yeah.
And now they came to bite us all back, you know. And me and Jatola suffered from it a lot because the nurses were like, oh, no, they have to be pain-free. You had heart surgery, there's going to be at a certain level of pain acceptable. You just have your chest cracked open. And so you saved your life, there's a certain level of pain acceptable. It doesn't sound compassionate, but in the end, it saves your life.
Absolutely.
So,
Obviously, I mean, so again, big money, pharmaceuticals, how you're perceived, how is it propagated, the message and everything. Obviously, all of them play a role. And as you rightly pointed out, it can be very, very attractive. It's considered a cool thing. And that's why, if you look at the original Marlboro ads, yeah, I want to be like that guy.
the mustache, the horse,
the mustache,
the hat.
the horse, it's with the Wild West, everything is all great and everything else. But you know what? As one of my very good friends used to say, the sins you do in your teenage years and young age catch up. They start showing once you grow old.
I like that, Jatola. I'm going to use that line.
I just want to make sure, though, because I have some questions too. But do you have any more slides?
No,
This
we
is
are
the
done
last
actually.
slide. Okay,
Yep.
good. So, thank you very much. That was an excellent presentation.
Thank
Sorry
you.
for the-
Thank you.
Sorry for the hiccup, but that was extremely informative. Okay, so you talked about, if I could, you talked about the vape and how the vape is affecting the lungs, and you know thought that maybe the oil's in it or whatever. Has there been anything definitive that says what substance in the vape is causing the problem? Because you have the vegetable oil, you talked about the butane ash, the other various products in it, substances. Is there anything that really stands out in your mind as to what the culprit is?
So that's a very good question. We learned a lot from occupational lung disease, specifically people working in different industries where they've been exposed. So a lot of it is conjecture as of right now, knowing the chemical properties and the physical properties of what happens to when you inhale on a vaping device. So just the high temperature which is generated to vaporize things, you can have metal fumes just from that, like zinc, which is existing in it. And that itself, if considering considerable dose is given, can be injurious to the lung. It's an organic product at the end of the day, and you start burning it, it's like literally inhaling a wood smoke, similar to that. Again, I'm just trying to make a corollary to it. And that can be injurious because there's so many different inhaled volatile hydrocarbons which are there, and all of them are injurious pretty much. If the lung gets exposed on a regular basis, a higher dose or a consistent exposure to it, yes, they are. And things like you use, what is it, propylene glycol? I think that's the one which
Glycol's a
gives
big
that
one.
smoke.
Yes.
And propylene glycol, if you use it in a significant injury, it causes injury to the epithelial cells, respiratory epithelial cells. There are a plethora of compounds in it, and that's only from the cartridges where we know what the contents are. So that may be a reputable manufacturer, at least where we know what are the things they're putting it in. Now we have this whole homegrown industry of people using the empty cartridges and filling it with different kinds of things. Now, what are they putting in it and what are they doing with it? We have no idea. There have been reports where the fluid has been contaminated with different bacteria. You had endotoxin in it. Yeah, you inhale endotoxin. We use that when I used to work in a lab. One of the ways we used to generate sepsis or lung injury was inject endotoxins or make them inhale the mice.
Yes.
And yes, if you give it a higher dose, it is injurious to it. So we still don't know. Can we say there is one smoking gun? This is the one. If we take it away, that's it. Everything is going to be fine. We have no idea right now.
That's a very good point. I'll just make a quick comment. You can comment on it. And that is the very reason psychologically that we can get kids, 18-year-olds, to go fight wars and run around and shoot guns and have bullets shot at them and get blown up is the very thing that the companies use in their marketing strategy.
Absolutely.
Both psychologies, I think, are intertwined with each other. What do you think about this new coronavirus going around?
Oh boy, I think I have it. That's what I told everybody actually for the last 3 days when I had a
We have
bad
an
cold.
ECMO circuit back there. We're going to put you on.
I have, it's scary, to be honest. Again, tells you how little we know about all the different respiratory pathogens which exist. Why are we seeing all these plethora of new things like SARS and MERS? Probably more interaction between human population and different sources. We still assume it came from an animal source that traveled. It's very easy. It's like you have a flight direct from here to Sydney, 16 hours from Houston. So imagine a lot of people are a lot more mobile, even though they may be in a prodromal phase or in an asymptomatic phase, they still shed the virus and they land up in a whole new population out there. It is very scary. If you read the news, China, literally, I think 6 cities are on lockdown now, 22 million people.
I knew one was, I didn't know six.
Oh, now it's 6. So 22 million people literally are in lockdown. Nobody can fly in and fly out, but we still have cases reported in Australia. We had one from Washington. There's some suspected case in Texas, I heard. Again, it's through the grapevine.
Yeah.
And Vietnam and everywhere else, it's popping up essentially. The way to look at it as an epidemiologist, as an infection disease, is one, you have the virus and how, or any sort of pathogen, how virulent is it, in the sense, can it kill a person if you get infected from it. The other aspect which you talk about is the host response to it. As a host, are you able to tolerate it? Like, not to sound difficult, but like Native Americans, they were never exposed to influenza and different measles and things like that. When the Europeans landed in, whole populations got wiped out because they never had the innate immunity. That was the host was impaired. I think that's a combination of both of it which we are seeing as of right now. It is scary. Unfortunately, as you know, there are very few viruses. There are a handful of viruses which can potentially treat. What do we do with this new one? I have no idea.
It'll be interesting to see if,
Yeah.
with Tamiflu, we don't even know if it would be of any value.
That's right. That's right.
And what other interactions. So I only had 2 more questions, and then I'll give somebody else a chance here. And they're sort of intertwined with each other, if you don't mind. And that is, where do you see ECMO growth going in the next 5 to 10 years?
That's a very good question. So what I've seen, obviously, so I started my training in 2003. It was still the era of HeartMate 1. This clumsy, huge device. I still don't know how patients carried it. And bypass circuits have been there for a long time, and we all knew the challenges was how can we make it to run on a consistent basis, not facing all the things which we face when blood circulates through an extracorporeal circulation. That's the age we have come forward from, to a point where we can put a cannula in and run it safely. What are the challenges which we see? It is still a very artificial thing. We still have not found the perfect biocompatible membrane which can line the tubings that it would mimic what a blood vessel would be like. It's still artificial. You must have seen it. Some patients' LDH remains fine, and some patients, in spite of everything, their LDH goes up. Some people tolerate a pump okay, but other people don't do it. There's some patient, I think Dr. Hani probably knows about it. There was this young kid, I still remember, came from Kingwood, I think, fractured his ankle playing soccer, developed fat embolism, full-blown ARDS. I've never seen jaundice in an airway. When I did his bronch, it was yellow. I thought there was something wrong with my scope. The guy's bilirubin was 40. Why is that patient different from another one? We don't know. But again, I think that's where the biggest challenge we still face is that biocompatibility of the interface. Is it going to explode? Absolutely. We have seen an explosion in the last 10 years thanks to the influenza virus and H1N1, where people realize it's actually safe to use it in adults. And as we have learned, similar to in transplant, that better management techniques, I think it's a very useful tool. But to put it in perspective, just because you have a hammer doesn't mean you need to start finding a nail everywhere and nail it down. In prudently, carefully selected patients, it can be life-saving, absolutely. I think that's my take.
I agree with you on that. I'm curious about Dr. Samir's opinion about that as well. But my second part of the question, which both of you can sort of address, is why is it, I understand there's this hyper-inflammatory response that takes place with people that have a virus. They get ARDS, they get a regular influenza A. Patient A just gets sick and does fine. Patient B, in particular younger patients, tend to have this hyper-vigilant inflammatory response, and they go into full-blown ARDS and end up on ECMO. What is the mechanism by which that happens, other than youth and a more aggressive inflammatory response type of thing? And is there a way to attenuate that if we knew up front the patient was at higher risk of having ARDS secondary to some kind of viral infection?
To be honest with you, I think it's the young age can mount higher immune response. That's what I personally believe. And you really cannot predict. Some young person can take Tamiflu and go home and sleep, get fluids and be fine. And somebody with a heightened immune response will mount a huge response to the virus and will end up on ECMO. I think it's only inflammatory mediated. Why that happens? The problem is the genetic predisposition that we don't know yet.
Good, that's my point, is there, if they could identify that, would there be a way to take a patient, like, because a lot of times we put these patients on ECMO, and you've seen it many times, they go on ECMO, and the inflammatory process, that immune response, their lung x-rays get worse and worse and worse and worse for several days before you starting to see it get better. They always get worse before they get better. Would there be a way to block that?
That's a very good question. Like one of the ways, like people ask me about stem cells. The way I tell them, hey, just because you have concrete doesn't mean you can build a house. So you need to have bricks, you need to have wood, you need to have a good person, you need to have paint, so make a wholesome structure. So similar to that, lung is a very complex organ. As such, just the fact, there are two predominant cells does not mean much. It's a lot more complex than that. Can be just an interplay, say a virus infects an airway epithelial cell. How does it react to it? Is there variability in it? How do the adjacent cells react to it? How does it play a role in the whole organ? We still don't know. It's very easy. It's a low-lying fruit to think, okay, we have all done it. I've done it in the lab where I try to manipulate one gene. I know in a bigger picture that yes, maybe altering one gene may not make much of a difference unless you're talking about sickle cell disease or something, which are very few, where you have a single mutation and that's a downstream effect from it. But in these kind of diseases, it's very, very difficult. Now, when we talk about attenuating an immune response, we have a lot of different medications we can knock immune response off. But the downside of it, is it actually a good thing? Sometimes you need to have your immune response to fight against whatever the inflammation is. They themselves have a dampening effect on deleterious effects of it. So again, shows you it's a lot more complex interplay. As of right now, I don't think our knowledge has gone to a stage where we can do that personalized, idealistic approach based on what the genome of a person is, and this is the optimal strategy for him. We are still not there. Hopefully down the lane, maybe in 20 for 50 years or something, maybe we'll reach it, but as of right now, no.
And which patient you're going to give Tamiflu to, and which patient you're going to give IgG to? That's a huge decision to make.
That's right.
Because nothing is without a risk.
That's true.
It's true.
Maybe I've seen cases. The first case I saw in bad influenza, which was eye-opening to him. Young guy, 48, an oil executive, lives in Oklahoma City, went with his girlfriend to Belize, coming back, had a layover in Houston, was feeling really, really short of breath, so he called the airport security. They landed him up here. Within 72 hours, multi-organ failure, full-blown VV to a VV ECMO circuit. Literally every organ in his body got shot out. But again, tells you, was just regular influenza. I had influenza that season. All I did was moped around for 2 days and I was back up on my feet. And this guy literally died, absolutely healthy. So obviously the way his body was responding to the injury was very different from what another normal person would be doing. Again, it's very difficult. As of right now, we just have this broad epidemiological tools. We know that if you have chronic heart disease or you have chronic lung disease, we know that those are the people will have more likely chance of one, catching the infection, more likely to be severe and more likely to be hospitalized and get what you call bad effects from it. So yes, that's again based on a broad epidemiological terms, and these are the people we encourage them. Absolutely, you need to get the flu shot. So again, can we expand it to everybody and identify it? We're still not there. We're still not there.
Tammy, Tracy, any questions?
No, thank you.
I'm more intrigued about the
Okay.
aspect of the high school kids.
Well, we are going to, thank you again very much. That was
Absolutely.
very,
Very
very,
nice.
very
Thank you.
informative. Okay, so we're going to move right on now to Tracy's talk.
Okay.
And Tracy is going to be lecturing
Borrow the
us
clicker.
today
Take it.
on the vaping crisis in our schools. So, Tracy, the floor is yours.
Thank you. And some of what I'm saying, I may say, may piggyback on what you were talking about, the ingredients and some of the pens and things like that, that I've researched from a different level because of the kids. I want to introduce you to Walker McKnight. Some of you may have heard about Walker's case. I've actually been in contact with the GoFundMe coordinator for Walker. This is Walker's senior picture in Orlando, Florida. He was a cheerleader, an avid jogger, worked out around 4 hours a day. So this is his senior picture. And this is Walker 2 months later.
Oh, wow.
Walker began vaping when he got to college because of anxiety and stress in college. And when he went into the hospital, he went to the doctor, presented his flu. Parents didn't know he was vaping. Roommate didn't fess up that he was vaping. Went to the hospital, ended up on a blood oxygen machine, in an induced coma, a ventilator for several months. When he finally came to, his exact words were, "I begged my parents to let me die." My correspondence this week with his GoFundMe coordinator, he will never be remotely the same kid again. He's 20 years old now. He is having to take dialysis 3 times a week. He's on the waiting list for a double kidney transplant, and they are trying to get him strong enough at this point to remove part, if not all, of his left lung because it is so destroyed from vaping. They found out he was vaping because his father went in and trashed his dorm room and found the jewel pens in his desk. That's how the doctors started putting 2 and 2 together with this young man. The lady that I'm communicating with, the GoFundMe coordinator, she said that she is absolutely thrilled that she knows that people all the way down in Texas are doing talks, and wanted me to convey that if Walker's story can reach one parent or one child to not end up this way, that she is thrilled that we're trying to do this.
Do you want to put that GoFundMe page up? I mean, do you?
I
do we
can.
have it,
I don't
or-
have it. I can pull it up for you. We can
Yeah,
definitely
if you just
do
tell
it.
us what it is, I'll look it up. and then
Walker
we can-
McKnight is his name, and it's his GoFundMe page.
Okay,
It's
I'll-
Mary Lynn Thompson is the coordinator.
Okay, we'll get that for at the end. Go ahead.
So-
Sorry.
Vaping by the numbers. I know that this is a lot of numbers on this slide, but I thought it was so important. As Michelle knows, I update this PowerPoint frequently because I want students and families to be aware of how drastically it's increased just in a few short months. If you look back in September when CDC started tracking more consistently, we were at 450 vaping illnesses and 6 deaths. If you jump forward to January 14th, this was the most recent study that I could find, we're at 2,668 vaping illnesses and 60 deaths across our nation. The illnesses have been reported to range between 13 and 75 years of age. So there's a huge range. On January 9th, just 2 weeks ago, we had the youngest death from vaping in the state of Texas, and actually nationally, we lost a 15-year-old female who passed away from vaping. I'm going to piggyback on that with this next slide because the youngest death was 15 from vaping illness. However, the youngest victims are much younger, and this is pretty staggering to me. This is recent as of January 3rd. This is the National Poison Control Centers. There's 55 of them across the nation. As of 2018, there were 1,892 children under 5 exposed to vaping liquids, and in most cases by swallowing them. Consequences include the vomiting, the respiratory breathing, seizures, irregular heartbeat. We did have one child in 2014 die from cardiac arrest from inhaling his mother's very sweet smelling candy flavored vape refill. I did see that in Melbourne, Australia, there was a 19-month-old that recently died from the same thing. The numbers for 2019 are not in yet, but the recent numbers that they said as of November 30th, they have 4,780 calls to the hotline just on vaping concerns alone, and that's of all ages. So people, we have commercials for Tide Pods. Put your laundry detergent up. Don't let your kids get into it. And again, it goes back to what you were saying about the marketing. There's no ad warning parents, don't let your kids and your babies get a hold of this because it can kill them. So that, I don't know if that's new information for anybody, but it's shocking to me. As you said, it was not until October that CDC finally gave this illness a name, which is EVALI. And as you also said, this comes on extremely quickly. Parents that I have talked to that have taken their kids to the emergency rooms report it as a severe flu, extreme fatigue, high fevers, vomiting, They take them to the emergency room, and of course, these kids are not saying, "I'm vaping, Mom. You know, I'm just sick. I'm not vaping." So usually, the doctors are playing catch up because they don't know exactly what's going on with these kids when they get to a hospital. Illnesses decline very quickly, as you saw with Walker. Organ failure, blood oxygen machines, comas, things like that, and especially in your younger kids because their lungs and their bodies are smaller and they can't process all these toxins as well as some of the older people. You mentioned the vitamin E acetate. That's the one chemical that the CDC that I've found has been able to isolate in at least 29 of the ill patients, so that at least they're making progress determining some of the things that are in the fluids that are making them sick, but there are many, many more that our kids just have no idea about. This is Dr. Eric Berneker. He's been very, very vocal in the city of Houston about the vaping crisis. He's with Houston Methodist. This was a study that I found interesting specifically on the crisis in middle schools in our area. This is from October. He says that these kids are reporting you get a really quick, really fast high that's really pleasurable, and that's because everything's going into your lungs in vapor form. Problem is, it's extremely addictive. Doctors are reporting it's about 10 times more addictive than cigarettes to quit smoking. Police officers that I've interviewed are stating that when they arrest these kids, and they are starting to arrest them, if there is THC oil in the vape pen, because it's so concentrated, it's about 4 times stronger when these officers test it than marijuana itself, which is a huge problem. Again, going back to middle school kids' bodies being smaller, their lungs are not developed, so if you're inhaling all this stuff, it's really affecting their lungs. I've talked to middle school teachers, Dr. Berneker referenced this. Kids are coming in from lunch, the bathrooms, whatever, bouncing off the walls. And we're talking 12, 13, 14-year-old kids. So, and that's, you were asking about the age range. This one's staggering. This is a new FDA report. Between 2017 and 18, vaping has increased 78% among high schoolers and 48% among middle schoolers. So that comes out to be about 1 out of every 5 high school students is vaping, 13% of middle schools, and guys, I can promise you that is highly underreported because our kids aren't being honest. They don't want us to know. So it puts educators in a bind, it puts doctors in a bind. It's a huge problem. This National Institute on Drug Abuse, this was really interesting to me. 30.7 kids who vape start smoking cigarettes within 6 months of vaping. The reason for that is because once you vape, you have to start increasing your doses to get the same buzz you were getting from vaping. So you're having to do more and more and more. So they're turning to cigarettes to get that more consistent nicotine buzz. You were asking, Joe, about what's in it. This is some of the chemicals that I've consistently been able to research that are in vape pens. Lead, aluminum, glycol ethers. Glycol ethers are found in cleaning solvents and water-based paints. Our kids are inhaling this. Diacetyl is a huge one. Back when microwave popcorn first came out, it was an FDA-approved flavoring. It was the butter flavor. What happened, though, was in the popcorn plants, the people that were manufacturing the popcorn were inhaling this butter-scented, butter flavoring, and people started getting very sick. There were deaths reported, and when they did the research and they started looking at lungs, diacetyl, actually there's a term now, it's called popcorn lung, because the diacetyl will get into the, and correct me if I'm wrong, it gets into the very small capillaries of the lungs and literally inflates them like popcorn if you look at an x-ray. Our babies are smoking this. Vegetable glycerin and propylene glycol. You'll hear kids, if you hear slang term, I've got VG or I've got PG vape. This is the difference. The vegetable glycerin is a very thick, syrupy, vegetable-based fluid. This is what, when you inhale it, it's essentially an oil. That's what creates the huge cloud of smoke that's so trendy with our kids. They think that's cool. You see them, and there's ads, just like we were talking about, ads with all the smoke and everything. That particular chemical is a VG-based vape pen. Propylene glycol, if you know somebody with asthma, yes, it's used in the medical community in very, very small doses in an asthma inhaler. So you can imagine if somebody needs that and they inhale it, how it inflates their lungs to help them breathe during an asthma attack. In vape pens, it's been found in very high quantities. So your lungs are not only inflating, they're really inflating. And this stuff is odorless, colorless, and very difficult to detect. So if our kids are smoking a PG vape pen, you're not necessarily going to get the huge cloud of smoke, and you're not going to have that real sweet smell. So the companies are getting smarter, marketing stuff to the kids so we can't catch them. One of the big reasons that Juul and other companies are getting sued is because they've advertised that it's so much safer than smoking, especially the secondhand smoke. However, repeated studies by the FDA, CDC, and the Drug Council have shown that it's extremely deadly, and formaldehyde has been found in secondhand vape smoke repeatedly. I don't know about anybody else, but I didn't get up this morning and want to go smoke some embalming fluid or breathe it, but that's been found in the secondhand smoke in our vaping. This is the Institute on Drug Abuse report that I was talking about. You can see that 30.7% of kids who vape start smoking within 6 months, and this is a very recent study, as opposed to 8.1% of kids who don't vape start smoking. The quote at the bottom, per Juul's website, 1 vape pod is equivalent to 1 pack of cigarettes. Our kids do not know this. And that is actually out of a Texas educators journal that was just published in December of 2019. What really scares me, as I was talking about, our kids don't know what they're smoking. 66% of kids who are vaping think it's cool, it's trendy, let's go to the party, and they think it's just water and simple organic flavors. I've had that, oh, Miss Tracy, it's organic. No, sweetie, it's not organic. So they just don't know what they're doing, and it's making them sick.
But, and I don't mean to interrupt your
Oh, you're
flow,
fine.
but do they really care? I mean, you know, kids are kids, and I'm invincible, and it's not going to hurt me.
Some do, believe it or not, some don't.
And if you tell them, is it really going to change their behavior?
It depends on how you approach them. If you lecture them, they're not going to give a rat's behind what you're telling them. If you sit down and try to talk to them and just say, hey, this is information that I have that it scares me for you, there's different ways to approach it.
Okay, I'm sorry to interrupt
Oh, you
you.
didn't? No,
We'll
you're
address
fine.
that. That's
No.
a very good point.
No, you didn't. You're fine. This was another recent study from November 5th. Channel 13 did a really in-depth story on the problem in vaping in our schools. And they interviewed over 1,000 different school districts and asked them for data. In 2018-19, and keep in mind this is a standard school year, so they're not their summers, they're not their Christmas or spring break, all the other holidays. 15,000 vaping incidents at school were reported across the state in 1 year. That averages 82 vaping incidents a day across the state. Just 2 months into this year, 3,800 vaping incidents have been reported, including many reports from elementary schools. The most recent one that I could find was a 5th grader, 10-year-old boy, was busted vaping on the playground at an elementary school in Jasper, Texas. So they're getting younger and younger and younger. Again, this is highly underreported, and there's many reasons why. Texas Education Agency does not mandate that school districts track at this time. HISD is the largest school district in Texas, and they do not track. They were actually one of the ones that refused to provide data in this study. Recent study, didn't have time to add it. It actually came out, Channel 2 did one on the 23rd of this month, if you want to Google it or look it up. They have a list of all the school districts in the state that are tracking and those that aren't. Very impressed with some still have a whole lot of work to do. So that's one of the reasons it's so underreported. That and our kids don't tell us.
So I find it very fascinating that at 5th grades, what do you think is the access? Is that the reason why there's so many of these kids out there?
I will get to that in just 1 second. Access is big. To go back to the access, one of the things on this, vaping in schools, how are they getting it? How are they getting it? I talk to kids, you can Google it and you're going to get an answer, oh, it's the advertising. I talk to multiple students, high school kids, junior high kids, kids of my friends. The number one answer is, I got it from my parents.
Wow.
I have a student that was real blunt with me and said, Miss, you know, I wasn't going to be cool if I didn't vape at the party. My dad vapes so much, he's got like 27 vape pens in the car, in the bathroom, in the kitchen, in the house. So I took one of his. He didn't even miss it. So a couple weeks later, his vape pen goes missing. He thought it got taken at the party or whatever, so he went back and took another one from his dad. Wasn't until a couple weeks later that he's getting screamed at for being an irresponsible big brother because his 12-year-old brother got busted at school for vaping. It's a junior high kid. And then he told the school, I got it from my brother, who then in turn had to say, well, I got it from you, Dad, because there's no conversation going on. That's the predominant one that I'm hearing from our students, is they're getting it from either older siblings or parents. They're also getting it from, they're just paying older people that are legal to buy it to go in and get it for them. They'll pay them on top of what the vape is. They also, I can promise you, they know every vape store that doesn't card and doesn't care. And they'll get it if they want it. And if they can't get it, going back to your point, the DIY vaping liquids, if you can't get it, they're gonna find a way to make it. And if the FDA can't even regulate what they're buying, what's being made is even more scary to think about. There's a huge drain in our public schools on finances for many reasons. And you also have to think about the disruptions on our students and our staff in classrooms trying to learn. There's increased police involvement, which is another expense. We have to think about that many schools, and they are having to resort to taking bathroom doors off the bathroom stalls because kids are going into the bathrooms and vaping so frequently in the bathrooms. So then you're looking at the maintenance crew, more expense on our schools. Some of the school principals that I've spoken with have said that they are having to pay extra hall monitors and pay people to stand in the doorways of the bathroom to prevent kids from vaping. If you can't catch them, what's happening is they're getting back to class and they're bouncing off the walls. Again, disruption. Student consequences are kind of all over the map. They range from a slap on the wrist to in-school suspension or D-Hall to full-on suspensions to expulsions to placements at juvenile justice education alternative schools, all the way up to felony possession of a narcotic if you're busted with THC in a vape. In the state of Texas, a kid can be charged with a felony at 15. So this is life-altering. I mean, if you get popped and you're charged with felony possession of a narcotic on a school campus, that's on your record. That's not going to go away. Why is there such a wide range? I've talked to several principals at different sized schools, different high schools, different junior highs. Because Texas Education Agency doesn't have a specific code of conduct for vaping, and here's why. It makes a lot of sense. They have a specific code of conduct for nicotine and tobacco and cigarettes. So if a principal or a teacher catches a kid with cigarettes, you know what the law is, you know exactly what to do in that case. We also obviously have a very specific code of conduct for THC, for marijuana. There's legal ramifications. How much do you have? Is it a misdemeanor or a felony? Are you expelled? Very specific. Well, here you have vaping. It's a whole anomaly. It's kind of a combination of all of it. So there's no code yet how to adequately track this. A real good friend of mine works at an extremely large high school, and I think there's 8 assistant principals. They're trying to track, but one may code it as a substantial disruption in a classroom because kid breaks out a vape pen in class, which happens all the time. Or one might, I'm not making that up. Really, they do. And so you code that as a substantial disruption. Another principal may be coding that as possession of paraphernalia. Another may be coding it as possession of a possible nicotine paraphernalia inhaler. So you can see they're trying, but until they come up with very consistent ways to track this, we're not going to have accurate numbers. I know a lot of school boards are going back to the drawing board this summer, trying to keep up with all the new laws and changes, so I'm hoping we'll see some improvement in that next year. Any questions?
No, as a school, can't you say that vaping is banned?
You can.
Like the example, I find it very surprising. A kid would just start vaping inside a class.
My daughter said it happened in one of her science classes all the time because the kid would just kind of sit at the back and
And just
you know, and the teacher was too busy trying to do what she needed to do.
Teach.
Teach. Exactly. Right, exactly.
That's scary.
It is pretty frightening. These are really, really good. Some of them are obvious, but going outside a lot, going to the bathroom a lot, unexplained sweet odor. That vegetable glycerin-based vape with the huge clouds, you cannot mistake the odor. It's super sweet, super thick, syrupy almost. You're gonna smell it on them. Mood swings, these are huge. Again, I mentioned bouncing off the walls. It can cause extreme rage, extreme anxiety, especially if you can't get to a vape pen. And one of the things that's very interesting is if your kiddo is drinking caffeine along with vaping, those mood swings and explosive anger are way up here. Caffeine and vaping don't mix. Unfamiliar gadgets and electronics, and I'll show you some of those in a minute, increase thirst from their mouth being so dry from the smoke. Nosebleeds, mouth sores, and persistent cough. Those can be indicative of a kiddo who has vaped for a while, but it can also be very sudden onset because, like you said, these illnesses are coming on so quickly. How to hide your juice in plain sight. Could not make this up. This hoodie, if you can see this hoodie, you can buy that on Amazon. Wow. If you've got your Amazon Prime account saved, not bashing Amazon, I love them, but if you've got it saved, all your kiddo has to do is go on there and order this hoodie, and it hides the vaping in it. The strings on the hoodie are actually the straw. The cartridge is in the neck of the hood. You can Google it. There's hundreds of places to get these. Some of them do not ask for an age. The one at the top, what look like cute little hippie kind of highlighters that are really like marketed towards junior high kids, aren't they so cute? Those are what are called puff pens. Those are actually individual disposable vape pens. Well, if you see a kid with one, it looks like a highlighter. The next one, it is a fake credit card. The vape pod is actually inserted inside the credit card. It's very thin, you'll miss it. It sits in somebody's wallet. It looks just like a credit card. Tic-tac-toe, this one's great. If you see a kid with these, the Tic-Tacs actually rattle. They actually shake. So if you catch a kid with this and you're not really looking for the vape pen in it, you're gonna think they just have Tic-Tacs. The one at the bottom, the little computers, those are actually disposable cartridges for vape that go in a pen. If you see these in a school, you're gonna think they brought their homework to class or they've got a project. The lipstick, it comes in a variety of colors depending on what your young lady wants to wear. That is actually a vape cartridge. There is one that looks just like an iWatch, that the cartridge where the iWatch, the face of the iWatch is on top, it pushes forward and you can just sit there and vape underneath your sleeves. School districts, some of them have started doing a no sleeve policy where they make the kids keep the sleeves rolled up. Some are going so far as to resort to no hoodies in class.
Oh, goodness.
So, any questions on that? Shocked?
I know human ingenuity is great. We are the most
marketing
successful
your money.
species, but that's like,
Yeah.
that's impressive.
It is
And it's scary.
In a
in
very
an
s-
very
in a
bad
scary
way.
yes, in an
Yes.
evil way almost.
Yes.
It is. And this is what our teachers
I
and
can
our
ass-
administrators are up against every day.
Yeah, I can assure you, we remember this years ago when the cigarette companies, the tobacco, big R.J. Reynolds and all those people were being hauled, in front of Congress and all of the lawsuits and so forth, and claiming that the cigarettes aren't causing all these problems. There's nothing wrong with these. It's not what's causing cancer. Even though John Ochsner or Alton Ochsner identified that along with tobacco.
That's right.
All the way back in the 50s, they knew that. But when asked, do you smoke? Do your children smoke? Will you let your children smoke? It stumped them
Right.
all the time. And these people, I think those people, and I think these people that make this, they're evil. Sorry.
But again, the intent behind the whole thing, if it was something very acceptable and people did not know it, you don't need to go through all these innovative ways
Exactly.
of hiding
Right.
it.
They
That
know
itself
something's wrong.
shows. I mean, it's crazy. People who are manufacturing it know very well this is not something which is acceptable to do. And just finding innovative ways of hiding that. It's
Well, speaking of hiding, there are actually, and they look just like Coke cans, Diet Coke cans, whatever flavor soda your kiddo drinks. and it actually unscrews. And so if you see a Coke can or something like that in your kid's bedroom, it can be a mini safe to put their vape pens and pods in, so you just don't see it. But there's hundreds of these. I just had to narrow down, but there's hundreds of these, and this just shows you our kids are getting creative. They either don't care or don't want to know.
Well, the adults are getting creative
Yes.
Yeah.
in manufacturing this.
Right.
That's right.
The kids are just taking advantage of
Exactly.
other people's ingenuity, which is making those people, who I again will say, unashamedly are evil, getting rich. But I'll let you go on. I'm
Oh
sorry.
no, you're fine. You're fine. But there are multiple sites you can buy this from, and like I said, not all of them ask your age when you click in, or you can just lie and say, "Yeah, I'm 21," and they'll let you right in. What's being done in Texas? Recently in Sugar Land, I admire the heck out of this kid. There was a 17-year-old senior at Dulles High School named Mattel Mullis, and he was reporting that about 90% of his friends were vaping. And he was fed up with it because his friends were starting to get sick. He had done the research. He knew the secondhand smoke was dangerous. So this kiddo went to the Sugar Land City Council and petitioned, "I want this banned." Well, they listened. So Sugar Land City Council passed an ordinance that anyone caught vaping in the entire city of Sugar Land is subjected to a $500 fine. I think it's brilliant. I wish more people would find their voices. 17 counties across Texas have followed suit. Multiple college campuses have as well, prohibiting e-cigarettes anywhere cigarettes are not allowed. We were actually one step ahead of the federal government here. September, Greg Abbott, our governor, signed Senate Bill 21 into effect, raising the age of vaping from 18 to 21, being able to buy. And like I said, school boards across the state are working really hard. They're playing catch up. They're scrambling because this is such a new epidemic, but they are working really hard to try to come up with accurate codes of conduct. And again, I'm hoping we'll see some improvement with that over the summer.
And here's a question I have. We have such a pervasive thing. It's very well accepted now. You can't smoke inside
Right.
hospitals or in a flight. You have all these things. So why don't we have it legally, like even in Texas? Any place where you cannot smoke, you should not be vaping there too.
I agree 100%, but again, it's a new phenomenon, and so we're going to have to start using our voices and going to our councilmen and our boards, school boards, hospital boards, to make sure that it is banned. I agree 100% with you, and I've asked that question a lot.
I mean, back in the day, when I came here to now, you can't even go and smoke inside a bar anymore.
Right.
I mean, it's the most frequent place people used to
Right.
go in and hang out. Everybody has been banned to the backyard or in the side alley, and you have your own little smokers, what you call.
I'm starting to
space or
see
something like
signs.
that.
You're probably going to start noticing them on restaurants and movie theaters and things, and you'll see the no vaping along with the no cigarette. But that's been within just the last few months,
Yeah,
which
that's very new.
Very.
Because I can remember in this previous year, going to a movie theater, even a children's movie, my kids, and people are vaping everywhere. And even if you ask them, could you step outside to do that?
They
I'm
won't.
not bothering you.
right.
This is safe.
It's safe.
There's
you
nothing
can't
wrong
make
with
me-
this smoke.
Right. Right. So it is new, but again, we're playing catch up because this has been in our country since about 2007, and we didn't regulate it then. So we're way behind. What's being done federally? As you mentioned, January 2nd, President Trump signed into order that all flavored, either that smell like or are flavored like mint, candy, desserts, that type of thing, those are banned, along with raising the federal age of purchasing vape to 21. Nicotine and menthol liquid and the large canister type that are not like the puff pens that the kids are using, those are still legal. And part of that, is probably a money thing with the nicotine companies, but the other part of that is some of those cartridges were marketed effectively for step down from cigarettes for adults. So there's that gray area that they were marketed correctly from the beginning. This is really new. All companies who want to produce any type of e-liquid, they have to submit an application just like a tobacco company would to the FDA by May 12th, proving that their product is appropriate for the protection of public health. So that'll give us a little bit more ability to regulate what's being sold. 13 states have banned vaping altogether. Minnesota is one of many, many states that has sued Juul, and the way they're suing them is for marketing our kids, targeting our kids through the marketing and the advertising of unsafe nicotine. So that's how they're starting, in answer to your question, to try to target the advertising.
Absolutely.
But again, our states are going to have to be the ones that are suing. This again, I talked to a lot of kids about this. How many of y'all have been there where we need to talk? Oh no. Okay, well the kids want you to talk to them. The first thing they want you to do is really listen, listen, listen. And the reason I say that is because sure they're going to tell you, oh, it's my buddies, he left it in my car, oh, blah, blah, blah. But they want you to at least hear them out. And then as a parent, you need to really pay attention to what they're telling you. And don't be afraid to have a very difficult conversation. I had several junior high kids say, you know, I really wanted to ask my mom, is this really safe, or is this something that I can do? But I was afraid if I asked her, she was going to assume I was already doing it, or I was going to get in trouble. So don't be afraid to have the difficult conversations with your kids. I get this all the time, but if I look at their phone or if I go through their room, I'm spying. You're not spying on your kids if you're paying attention. It's a totally different thing. Kids also say, please give me appropriate, consistent consequences. Like, don't ground me for a week and then change your mind. Oh, you can have your iPad back today because it's easier for you at dinner, and then take it away again. I don't know if that makes sense, but
Absolutely.
the other thing parents can do, again, use your voice. Go to your congressman, go to your senator, go to your local city councils, petition that vaping be banned in your county. Use your voice. And I think that those are some real important tips that we all need to remember that we're in control of. Any questions, comments, thoughts?
I think we have a lot. Tammy, I'm gonna let you go first.
Okay. I guess what I want to know is, you talked a lot about the VG versus PG. So do you think that PG is now the way that they're going to be marketing so that people are able to do this in a less conspicuous way?
Yes and no. They're trying to go towards a blend, actually, and there's a reason for that. The PG burns the back of the throat, and you'll read all about it. It's called the throat burn. That's your desired throat burn, or your desired throat buzz. If you read a lot about the VG versus PG, the VG is more flavorful. It's less of an immediate burn at the back of the throat. The PG is I think probably because it's that inhaler hits the back of your throat. It's kind of a user's choice. Most of the research I've seen is they're trying to come up with a combination of both. So, but you can hold your breath. You can hold your breath, and if you do hold your breath long enough, even with the big cloud, and you hold your breath and you keep your head down, it's eventually going to be absorbed, and you're not going to see the huge clouds.
That's incredible.
So,
That's all I have for the moment.
okay.
Dr. Soma?
I'm just, I don't know what to say. It's very scary, actually.
Yes, sir.
To be the way the market. I did not know all of this, to be honest. I thought it's only Juul or whatever it is, but I'm still very surprised that we have so many rules and regulations on different things, and this is still happening. That's what I'm really, really, really surprised about. That we are able to openly market it in such innovative ways, and even where we start off, schools and places like that, it's acceptable to do it. I don't know, is it a failure on our part as a regulation, parenting? I have no idea, to be honest. And that's a conversation. It's very eye-opening. I have two young kids, they're 10 and 8, and now I need to actually
Right.
seriously look into what they're doing actually when they go home, when they go to school, and what are they getting exposed to. That's it's very surprising.
A friend of mine that's a principal, again, at a large school, told me that they're averaging between 5 and 10 incidents a week. So you can imagine the teaching, the distraction from teaching, the time away from the administrators actually monitoring the whole school dealing with this. The nurse being involved on some occasions. I know Tomball High School had to ambulance a student to the hospital back November. Was it November-ish, I think? So the time away from just actually going to school is huge. If you think about between 5 and 10 incidents a week. So it's kind of all of what you said, it all needs to be
Gotcha.
looked into.
So is there a groundswell going on? Means, I think schools are very essentially establish all the habits as an adult and what the norms and everything are. Do you see anything going forward, at least in Texas, which is relatively more conservative, I think, a lot more stringent in these aspects?
Yes, I do see that they're trying to get more stringent, but until we have actual codes of conduct in place from the state lawmakers, it's going to vary from district to district. Private schools have a lot more ability to, you're expelled. It's in my code of conduct. They can update theirs a lot more quickly than public school districts, and that's not a criticism to them. It's just that they're governed by the state education agency.
Gotcha.
And it trickles down. Now, some districts, like I said, are doing an excellent job tracking. Right on down to something as simple as this was an Aldine ISD officer, 6th grade student in possession of clear e-cigarette device on campus. That's pretty clear. So I'm hoping that more districts follow suit and that we can come up with more consistency. Did that
Dr.
answer your
Samir?
question?
I think we're gonna have to look at the negative reinforcement ways. You know, sometimes you go positive, but kids have to know what's gonna happen to you. You end up on a ventilator, and that parents have affected kids have to share more to help other kids see what's gonna end up. The end result is gonna be.
Right.
I think that's gonna help a lot. And so people who have encountered the drama, you need to share so other kids can see this is where you're gonna end up. This is how with lung cancer in that situation we went around it with smoking. So
Little
we
shock
should
value.
we should not be afraid of shock value. We try to cuddle people and don't do this, don't do it tomorrow. No, you need to see the effect of doing this. There's nothing wrong with showing negative results. We cannot be touchy-feely all the time.
But I think you need to do that, and I know this may seem a bit harsh, but that needs to be done when they're 5 and 6 years old.
I agree.
Not when they've already started with the risky behavior.
I mean, being in detention is not. I don't think it's gonna do anything. Kids don't care. They'll just take it as a break.
Well, you expel them, but the parents skate, and they got the vape pens from the parents because the parents and siblings and everybody else is vaping at home because everybody thinks it's so good for you.
Right. Everything.
But when they see a picture of a young athlete who's now on a ventilator and probably will never recover, and loss of muscle too, and loss of cerebral function, how that's going to be like, or how he's going to need maybe 24-hour care future life, and end up in an institution. I think this kind of things is.
Well, I think, there's a big push, even in elementary schools, they have the drug-free week. I think this needs to be included because I have a 5th grader and he knows people who are vaping in his school.
Wow.
Oh, I believe you. Oh, I absolutely believe you.
He's 10.
And I do presentations in schools when you're welcomed in. Some school districts, they don't want to talk about it because they don't want their rating to go down, like from exemplary to standard or
Right.
whatever. So they don't want. Others are much more open on getting in there and letting professionals get in there and educate the staff and the kids.
And the other aspect which people miss, nicotine is toxic. It is a huge sympathetic stimulation it gives you. Like in a regular cigarette, majority of the nicotine actually gets burnt off. But if you consume it orally and a naive person, you actually can have severe cardiac toxicity from it. That's what worries me essentially is now we have this liquid filled with nicotine. I mean, so I'm sure if
Right.
kids swallow it or something, that's
But you remember the time when e-cigarettes were allowed on flights even? In the beginning, there's just okay to have e-cigarettes on flights.
Sure, it's just
So
water
that's
vapor.
why,
It's water
yeah,
vapor.
yeah,
It's
that's why they
fine.
thought it's so safe. You can have it on the plane, it must be safe.
Right.
That's right. But even if you walk to Methodist Hospital in the main building, I don't know whether it's still there or not, you have ashtrays in the hospital.
Yes.
I mean, it's like it tells you
Well, I
where
mean-
we have come from and everything else. But
I mean, I come from a time when the nurses would be smoking at the nurses' station, taking care of the patients in the ICU, and they had an ashtray. Do you ever remember that? Even in the
He took the words out of my mouth. Was that prehistoric? Or what is that?
Okay, so with all of that said, Dr. Matoyer has arrived,
Okay.
which is great. I know we're going to be. I have so many things that I want to say about this, and probably a lot of them are, ideology and philosophical and legal, and my thoughts about all of this. You're gonna have to commit to me, and Dr. Jothula, you're gonna also, Dr. Samir, of course, I know you will, because I'm gonna cook you a hamburger, and I know I can always get you here by just telling you I'm gonna cook you a
We'll
hamburger.
see today. We'll see how it looks like.
We'll see how it goes today. But you have to commit to me that we'll come back and revisit this in a part 2.
Absolutely.
Because this is just such a big thing, big problem. And I will tell you, Tracy, you did an incredible job with
Yeah.
this.
Thank you.
And
Great presentation.
I've
Thank you.
learned so much from your lecture that I just was unaware of.
Thank
And
you.
but it's caused me to have more questions than answers. I've got a lot of questions. But what we're gonna do is we're gonna have a part 2, so be looking for that. I'll
Okay.
call y'all. We're gonna take what do you think, a 10-minute break? Yeah. 10-minute break. We're back. Okay, welcome back everybody to our second half. As I told you in the very beginning, Dr. Samir had approached me about this program and had told me that he really wanted this program to be special. And so far, I don't think there's any doubt that it has been, between Dr. Jothula and with Tracy talking about vaping, lung injury, prevalence of this in our schools. It's been incredible information. But these patients are going to need something to keep them alive when they come into the hospital, and that's going to be, of course, ECMO. And we do a lot of lectures about ECMO. But I think, as you said, Dr. Jothula, and I think Dr. Samir, Dr. Matoyer, by the way, welcome. Dr. Matoyer finally made it in the house. Yeah. Thank you so much for coming in on your Saturday. I appreciate it a lot. Dr. Matoyer is a cardiac surgeon here in Houston, has been in clinical practice for nearly 20 years now. Am I right?
15.
15 years?
Yeah.
Okay, 15 years. He's also the chief of staff at St. Luke's, the Woodlands Hospital. Correct. And you are a UT graduate, medical school, but you did your cardiac.
Texas A&M.
Texas A&M.
Oh,
That's
be
right.
careful.
Yeah, that's right.
But I did
That's right.
finish up with Dr. Cooley.
That's right.
Okay.
That's right.
Biggest
You did.
Longhorn ever, yeah.
That's actually what I meant was your
Right.
your cardiac fellowship.
Right.
So you were one of the last fellows that was trained with Dr. Cooley still operating.
Correct.
And I remember we met with him in his office, and that was pretty impressive. But you have a lot of experience with ECMO, and we've actually discussed it on some of our programs, some incredible saves. Lady who was pregnant, delivering, was going into failure.
3 of those.
Yeah, and but that one case that I remember, because she was in heart failure, but you had figured that the heart failure was secondary to hypoxemia, and you made that decision very quickly to go ahead and do VV, get her cannulated, get the baby out, go on ECMO, and save that lady's life and the baby's life. You saved both of them.
Yeah.
But you've done a lot of remarkable cases like that, including having to stand on a bunch of stools with a patient that was so massive, and you only had a sliver about I don't know, it must have been maybe a couple of centimeters sliver to see the wire go from the SVC through the atrium into the IVC, and we had pictures of that. I think Julie still has them.
Right.
But I need to see
Not
those.
quite like the famous picture of Dr. Cooley with
Yeah.
all the residents around them,
Yeah.
but
It was pretty. Yeah, it looked pretty impressive.
kind of like a caricature version of that.
Yeah, it was pretty. No, it was pretty impressive.
Yeah.
It was pretty impressive. You certainly, you for some reason, because not everybody can say this, but you ended up where you needed to be, because you can stick some cannulas in.
Be
people
sure to tell
real
my
fast.
wife that.
I tried to.
She
I
thinks
tried
I should be a plastic
Okay, hopefully
surgeon,
she's
so.
watching.
No,
No, she's not watching.
She's not doing
no.
that?
I'm shocked.
she's shopping.
I'm shocked.
As expected, what can I say?
But Dr. Samir wanted to do a really special program. I think this is going to be. So we're going to be talking about ECMO now, and I'm turning this over to Dr. Samir. This is his brainchild to have VV ECMO cannulation strategies and weaning off ECMO and the ventilator, an expert discussion with slides with, of course, him with his ECMO experience, Dr. Matoyer with his ECMO experience, and Dr. Zothula with his ECMO experience, plus, of course, Tammy and myself from our perspective of all of this, and Tracy with her, I think, education experience. A lot of this information is going to be very beneficial for you, and you may have some great questions, but things that you can pass on to your students and parents and other major stakeholders in your current sort of passion and educational efforts on your own. So with that said, Dr. Samir, I'm turning this over to you.
Thank you, Joe. And really today is very special for me to be working again with Jotola, who's a good friend and a great person. And see Mark, I haven't seen him in a while. So I'm really looking forward to today. I wanted to start with something very simple. I know some audience are not medical, so that's why I want to go with something very simple. A lot of you know the schematic, but a lot of people should be watching about vaping that are not in the medical field. So to get the blood oxygenated outside, you have to get the blood from the left side, put it through a pump and oxygenator, return it back to the heart. That's the little schematic right there. And then we're going to go over some things. So we're going to talk about the indication of VV ECMO, cannulation strategies. We're all not going to agree, on some of them, especially Joe, because Joe likes to be combative. Why should we walk patients on ECMO? Which is a very important thing for me. If anybody has not seen this, what a general ECMO setup looks like, generally. A lot of equipment, a ton of nurses, a lot of money spending, a lot of people needed to help the situation. Putting people on ECMO, you should be considered very carefully. And here I'm going to pick on you, Jotola. Do you want to put the early ECMO or late ECMO?
Well, it's a philosophical question regarding, are you going to be proactive or are you going to wait? So for me, again, it depends on the perspective on a patient. Like you have an ARDS patient who walked in, I would rather try to be earlier on. Now we have so many different strategies, doing prone positioning, giving inhaled NO, keeping on these vent strategies, high tidal, high PEEP, low PEEP, and we have so many different things. But if you recognize at some point of time the injury is very severe, oxygenation is significantly impaired, and you are in that probably going to enter into that organization phase and later on into fibrotic phase. I think honestly, with the improvement in the technology we have and the experience, especially in experienced centers, I think putting them on a VV ECMO is a more prudent choice. But again, that's my bias, seeing both ends of the spectrum. I don't know, you guys can differ from it, but for me as a transplant pulmonologist, that's what I think.
No, just from my experience, early is better. And if you have the experience of seeing multiple patients, you kind of know which way they're going to go.
Absolutely.
To wait is usually, even for VV ECMO, certainly for VA ECMO, but for VV, they tend to not do well. And I think that's all because of ventilator injury. Not all, but a considerable part of that's ventilator injury versus what their true physiologic process is.
Yeah. But again, as you rightly pointed out, people don't assume it's just not the ventilator, it's a downstream effect from all of that. One, you can intubate them, you sedate them off, and especially if you're having oxygenation, troubles with oxygenation, everything, paralysis, all these things I did as a resident. This was, we are talking about 2003, almost 2 decades back. You're keeping them bed bound, more deconditioning and things like that, and later on going to a trach and maybe trying to wake them up, and then they can hardly move when you still are on vent support and everything else. I think putting them on an ECMO circuit, I think precludes a lot of that iatrogenic injury, which we do as part of the care or regular delivery or usual care, as we used to call it back in the day.
And it seems like what I'm seeing now is with earlier intervention on the ones you can reliably predict that need it, they don't get trachs anymore. It's still not uncommon, but before it was, they call you after several days of flogging them, and then you put them on ECMO, and then you add that extra 7 days, and then I just would trach them because they're so deconditioned at that point, it doesn't matter. So.
That's right.
So I'm a strong believer in early ECMO placements. Talk to the pulmonologist and surgeon, and most important, talk to the family. And my think about real expectations. Be honest and blunt with the family. This is the program that's going to happen. This is the complication, what the expectation should be. And I believe every ECMO patient should get an ethics consult pre-placement. Should not be a journal club for hours, but should be talk with the family and be like what the expectations are, what the endpoints are going to be. And this should be carefully considered. That's my personal opinion. Joe, any comments on that?
A lot, but we can go on and then we'll get to it.
Okay. And here, Sai says the same thing. Timing is critically. You think of ECMO, get the circuit ready. That's my opinion. Get ready and just and go for it if the family says okay and everybody's signing up. Obviously, you can look at things if you have a head bleed and you're going to have to anticoagulate, what you're going to do. Is that going to be feasible? Then it comes up trauma and ECMO. Should we put trauma patients on ECMO? But it's a whole other story. Are you putting trauma patients on ECMO?
It's actually, there is a big push nowadays actually, especially if you have acute lung injury, predominant contusions. But again, it's selected. Do you do it on everybody who walks into the door? Obviously not. But again, that's what we are learning as a group and as a field. What we have seen in the last 10 years, I think we have become better at identifying the patients who are going to, one, get the most benefit from it. I think that's where we are. Gone are the days where blindly it used to be put in and we'll figure out what's going to happen with it. I think we are more and more, I think, gotten better as a group in identifying it. It's still a field in evolution, but that's where we are heading to.
Well, just the anticoagulation strategies for it. I mean, we really don't give that much.
That's
I mean,
right.
We run very low ACTs
ACTs.
and PTTs, and sometimes we'll, just their coagulopathic process from their liver dysfunction sometimes will
That's right.
be the anticoagulation they need, and
That's
you don't want to treat yourself. I always discuss with nurses, don't treat yourself, don't treat the because the hemoglobin's 7.5 and a post-op heart patient and they're totally asymptomatic walking around the unit, you don't need to give them blood.
That's right.
Don't treat that number.
That's true.
So it's that's why the
Mark,
clinical
like I said,
aspect
my
of
wife
this.
makes fun of me. Sometimes you have to leave things alone. They look okay, leave it alone.
I'm super conservative. As far as surgery too, I mean, I'm pretty conservative. I mean, I have a longer discussion of why you shouldn't operate on somebody than you
Exactly.
should. So it's the clinical aspect of being conservative. You don't always have to do something. And that's unfortunately one of the philosophical problems physicians have, because we go into this profession wanting to help and do
Everybody.
things. Sometimes you end up doing the things to the patient, not for the patient.
Absolutely, you're right. You're
Yeah, I
absolutely
mean,
right.
and I think that's a very good point, and sort of going, those two thoughts, the anticoagulation and then the early versus late intervention. We have to come up with some better methodology, something better than heparin as an anticoagulant. I don't know what the answer is, but certainly we've had heparin for so long. I mean, you could use
Citrate,
Angiomax, you could use citrate. I mean, I think regional anticoagulation would be great, but given the flow through an
I don't know the
ECMO
answer.
circuit, the flow would be, if it was 200 or 300 cc's a minute, it'd be easy. But at 5 liters, you'd need an awful lot of citrate and you'd need an awful lot of calcium, and I don't think it would work. There just has to be a better way. And you don't only have the blood circuit to worry about, you have the outside of the cannula as well. So everything has to be non-thrombogenic, and I don't know I just don't know what the answer is. But in terms of early versus late, I agree with you. Sometimes you can do things, as you said, to the patient versus for them. But that line is so, at times, not only unseen
It's
or
moving.
somewhat hidden,
moving.
but it's
That's
just
right.
razor thin. And and I've seen it, conservative, physicians say, no, we're just going to hold off, we're going to wait, this, let's just keep doing this. And eventually you reach a point where you're unrecoverable. We'll put them on ECMO and you have a bad outcome because
Absolutely.
nothing you can do now is going to work.
That's all the bad data for ECMO came from late placement of ECMO.
Yeah.
Yes, but it still happens. Interestingly enough, and I think this is very important, there are many hospitals that are not far from where we currently are that even can do heart surgery that do not have the capability to do ECMO. Now they have the ability to essentially put somebody on cardiopulmonary bypass and then have somebody come to get an ECMO to move them, But how many patients in those institutions, and I know one in Louisiana, that a 25-year-old who would have, had they done some earlier intervention with ECMO, would have, 25 with the H1N1, it was back in that time, I believe would have survived. The patient didn't survive because they never had that capability and would not transfer the patient someplace that did have that capability. And I think that's, it's going to be interesting to see how it all plays out over the years. I don't know what you think, but that's what we see.
Absolutely. Now the other thing is now, Jatola, do you agree that everybody goes on ECMO needs to be put on the list?
For a transplant, again, it depends on it. The reason, I mean, again, it's a philosophical approach, which, like as a transplant pulmonologist, I'm more accustomed to VV ECMO. So the way I view a VV ECMO is it's a support device. And what are we trying to support? One is expectation, whatever the primary illness is, which has brought the patient to that point, is it going to improve and is going to go back to his same functional status? That's one of the first assumptions you want to make when you put somebody on an ECMO. You don't want to do it on, like, say, severe ILD flare up, and you know that there is no exit gain here. Right. What you're doing is essentially you're buying some more time, and you'll reach a point where, irrespective of how high a flow you may achieve, you will still struggle with oxygenating when the primary oxygenating device, or which God has given us, is not working anymore. The next point is essentially regarding selectivity, going towards a transplant. I believe if somebody, I mean, transplant is a life-changing surgery. It's a life-changing decision. Is it something which you would say, hey, I saw a patient in the ICU on a ventilator on high oxygen requirements, high PEEP and everything, I'm going to go say, oh, let's do a transplant? I don't know. I would rather prefer doing an ECMO as a bridge to a transplant, somebody who's already gone through the process, has met the whole team, he is motivated, he knows what the risks and benefits are, the family is ready for it. At the time of, or either he's listed or close to there, and something happens, the primary disease flares up, either it may be PAH and it got worse, and some reason he landed up on an ECMO for it, or his ILD and you have a flare up. Yes, as a bridge, but again, these are very carefully selected patients. Mm-hmm. Would we do it on everybody who walks in? No, I don't think that's a good answer. It defeats the whole purpose of it. Absolutely. And probably, I think that's also a downside as a physicians, a lot of the times we try to do things thinking that it may be beneficial to the patient. Back in the day, people used to give steroids. People thought it was great in ARDS. Then we learned it's not so helpful. Then people tried inhaled NO. It turned out to be not so helpful either. It was more good as a placebo. So yes, there is always an intent to see how much we can push the envelope. But we know, at least so far, I think we have accrued enough experience that it's not for every patient who walks in. We have to be very selective.
I'll have a more controversial questions about the listing for you when we get on the video, so be ready.
Oh, Lord.
And here's the indications for ECMO VV. Take a look and tell me what you think. You're smarter in this area than me. If you don't agree with any of this, let me know.
I mean, that's fair enough. Again, what is the intent of doing the ECMO circuit on this patient? If you're supporting the acute hypoxemic respiratory failure or acute respiratory failure, it's fair enough. That's what I would say. Contraindications, again, goes back into it again. If you have a disseminated malignancy stage 4 where you know that the life expectancy is probably very poor, or things like that, what are we trying to do? Buying more time for what? To what end? We need to ask ourselves.
What about diffuse pulmonary alveolar hemorrhage?
DAH, again, is a very clinical diagnosis. I mean, if you look at the textbook,
Right.
there are 100 million causes for DAH. It can range from anything. If you have severe ARDS, you will have DAH.
Right.
But that's just the physiology of or the injury. Essentially, does it mean anything? Again, is it a reversible cause? Is it a vasculitic phenomena where you can do plasma exchanges and things like that and reverse it? Absolutely, as a bridge, probably to a therapeutic intervention, which putatively will recover the lung function. Absolutely, you should try doing that. Well, again, the primary disease is not going to be changed. The primary disease is not going to improve. We are just prolonging the whatever. Again, it's obviously in this day and age, I think, as Dr. Hani was telling, it's something you have to discuss with the family, give them realistic expectations where we are going it and do it as a shared decision model, I think. I think that's where it should go to.
So just because I'm sure you've seen this, I've seen it, when you have a patient like that, and then say they're young and you're going to give them every shot and you intervene early, and then you got your ACTs as low as they can be, or your PTTs are almost negligible, and it just gets worse. I mean, I think it's just, I think it kind of, it is expressed its end result at that point. Because
Absolutely.
obviously it's not going to work.
That's right. That's
So,
right.
But again, the early intervention, give it a shot. I mean, it's 10, 15 minutes to put it in, more time for perfusionists and whoever to manage
Manage
it,
it.
but because it's labor intensive from that aspect.
It is transfusions, managing, because it's massive bleeding, you know, and your ET tube is just, I've seen them
I've seen them
turn
leave
into-
just a suction catheter hooked up.
I've
Yes.
done that.
Yeah, it's not,
Yes.
yeah, that causes,
Yeah.
yeah.
But I've seen them fountains, just
Yeah.
literally
Coming up.
looks like a spigot. And it's a real
But again,
problem.
it's the patient selection. I mean, if you're 80 and
Yeah.
you've got
Absolutely. Yeah.
stage
That's-
4, whatever, I mean, it's kind of a no-brainer.
Yeah, one thing of interest of mine, that's the air leak. Some patients have really a bad air leak that you think you should rest them on ECMO for a while. Do you believe in that or no?
No, I don't think so.
What was the question?
You have a bad air leak that's not healing, it's not closing.
No.
Oh, air leak.
I mean, again, we have, again, depends on, I mean, we have so many different
If they
things
have
which you
that
can
bad
do.
of an air leak, they probably need at least a shot at surgery to fix it.
Yeah.
And then if it's because their lungs are so bad anyway and their FEV1 or DLCO is low to begin with, I mean, I don't know what you're going to gain, to be honest with you.
Like, you know the glued stuff, put the glue, whatever.
Man,
Let it work.
I
What do
know.
you think?
Progel's the only one that does work, and it's not that, it's okay.
That's why I opened that subject, controversial subject.
Mm-hmm.
So, I mean, Progel and let it heal for a couple of days. What do you think about that? You know, the whole ventilator for 2 minutes really is not going to work.
No.
Yeah,
Yeah, that's
That
that's
is
an
like-
interesting question. I haven't had that happen
I'm sorry,
yet.
it's a little controversy.
But again, as you rightly put it, I mean, it's air leak per se by itself, if it's significant enough that it's impairing your respiratory function, either hyperventilation because you're unable to blow your carbon dioxide,
blast,
or hypoxia usually indicates that you have a primary lung disease, what we call a secondary issue, a secondary pneumothorax from whatever it is. Post-op, I think we have gotten very good at actually managing post-op. Means I do lung volume reduction surgery, lung volume reduction procedure just with bronchoscopic valves. They're FDA approved with one-way valves and very good response. I think we have great tools actually to
that's
address
who
it.
gets my patients that
Yeah.
are close to that.
Yeah, we have very good tools nowadays. Have you ever faced somebody with such severe air leaks that we just cannot inflate the lungs? It's usually been post-ventilatory injury, where high ARDS and bilateral chest tubes and air leaking everywhere. But again, that's probably a candidate who should have gone earlier on rather than like when literally as a last-ditch measure.
Can you talk a little bit of one-way valves? You know, because a lot of people don't know about it.
I mean, we can. I mean, now we have 2 FDA-approved devices. As you know, lung volume reduction surgery is one of the options which we offer for selected patients with COPD. So now we have endobronchial valves, which we do it. One is a spiration, one is a Zephyr valve. In selected patients with full integrity of their fissure, we actually can place it and actually do it just bronchoscopically rather than the usual surgery, with putative improvement in their exercise capacity and also in FEV1. So relatively new, it just got approved last year, so it's up and coming nowadays. So that is something which we use as a transition into transplant. If somebody has significant COPD, very hyperinflated, but they're not transplant candidates yet, this is one of the options we offer them.
Another controversy. Today I have controversy day for me. So if you have a double lung coming in with neutropenic, are you going to put them on ECMO or not?
Oh boy. That depends.
You have a patient that's less than 1 year out, has coronavirus. And now, I'm sorry, I'm being very controversial, but you can beat me up later. Are you going to put them on ECMO or not?
So that's a very good question. There's actually a couple of people looked back at ISHLT database, looked at 1 year mortality and 15th month mortality post lung transplantation. So there's a remarkable thing. The survival rate miraculously drops off 13th month and 14th month. And why is that? And so again, as you know, we live in a very regulated society. Transplantation is one of the most regulated ones where every data is public. You go to srtr.org, you can look at any program, how they're doing, what their waitlist mortalities and everything else. Is there a subtle unspoken rule that the numbers need to look good? Yes, that does exist. Is it unethical? I'm not sure. That's a very controversial thing to ask for. Again, going back just to the medical aspects of it, if a patient comes in, has a bad viral infection, suffered from ARDS from it, yes, we made a major decision that we're going to offer them a very precious resource. We want them to obtain the best benefit from it. As part of it, if ECMO is something we're going to think about supporting them through the transition in agreement with the family and everybody else, I think it should be done.
Absolutely.
Should it be done just, oh, I need to, it's just less than 1 year, let me see what I can do? That's a little very controversial. Again, everybody may differ in their opinion. In my book, probably not the right reason to do it.
No, and I agree with that 100%. I mean, to be honest with you, I really don't feel there is much contraindications to ECMO anymore except malignancy or head bleeds.
Absolutely.
I mean, I think everything is relative right now.
Yeah.
Okay, here's a little video. And we're just going to go talk through the video. This is about, so Mark, somebody comes to you for ECMO for like some like influenza, it went bad. What's your best cannulation strategy?
Well,
For influenza,
Influenza, I'm going to make it 35-year-old.
it's a IJ cannulation with an Avalon, or the Medtronic, whatever.
Crescent
Crescent.
or Avalon, yeah.
Crescent. Yeah.
So I'll tell you, I'll tell you my little opinion later, but fem I think is the easiest, but people, more experienced people like you can be, neck cannulation takes a little more time. Fluoro, echo, it's operator dependent, but
Yeah.
it's also capability dependent.
Right.
At 4 o'clock in the morning, in a major institution, you can get everything.
Right.
At 4 o'clock in the morning, in a smaller institution, get a TE, cardiac arrest jars available, and fluoro available in the OR. Sometimes it's a deal.
Right.
It is a real
The
drama.
TE has been the biggest problem.
Especially for Avalon, you need a TE for Avalon for sure.
I've actually been doing it without it because I know where the ports are, and I know I literally can, once I get, the main thing is obviously getting the tip and the inferior vena cava. You screw that up, you're going to hurt the patient. You get that in there, hub it all the way down, and then you can use fluoro to figure it out. Even if you don't have fluoro, and I've done it before, where like that lady that was so morbidly obese, basically I just finally could see the wire that was in the inferior vena cava. I knew I could safely put it down, and then just using, I hate to say it, color change on the cannulas, and you can figure it out by turning it, twisting it in the side port. If you always just turn it toward the face, you're going to hit it every time. I'm in the chest every day, except Tuesdays because that's clinic. But you can see, you know where the anatomy is to know exactly where to have these ports, put the oxygenated blood in the heart so you don't get recirculation. TEE, we do it if it's during the light of day, but if it's in the middle of the night, we don't. But yeah, I see what you're saying. Like if I'm at, say, one of our smaller hospitals and we do have the ability to do hearts and they don't do any ECMO, yeah, VV through the groin, super easy. And then you can transition them.
Exactly.
Then you can
them more.
transition them. The point, what you're trying to do at that point is just save their life and get them.
That's right.
And maybe even if you do it and the situation isn't right at your hospital, maybe you're by yourself and you and the perfusionist, where you can do the VV in the groin, and then in the next morning you can transition them out. We frequently make different cannulation strategies. Apparent as the day goes on, you can change them out. I've gone from VA. What was that one we had?
VAV.
We had VA and VV, and it was such a weird case. And
We've done VVV.
We did, yeah, that one what we most recently did for you. Wasn't
Yeah,
it
it was-
VVA?
he had VA.
Yes,
He
it
had
was.
he was having he had heart failure, and I thought it was originally from possibly hypoxemia, but it was left heart failure causing his right heart failure, and we didn't have a real good reason for it. Put him on VV, got better, and then he crumped again. Put him on VA, totally offloaded him. So basically, we had him on VA and VV,
Simultaneously. with
Simultaneously.
two
Two
circuits.
machines, yeah.
right? 2 machines, which I'd never done before. And the guy's doing great. He got fasciotomies for an ischemic limb, and that was it.
So that's one strategy. But now my preferred strategy, and I'm trying to agitate Joe as much as I can, is the Protect Duo. And I'll tell you why is this my preferred strategy. because I'm a fan of the RV. It's an orphan organ. I want to help out. It's an orphan. We want to help it out.
Pretty weak.
It's a pretty weak organ. You have to help it out. So I'll tell you, I feel like the Protect Duo gives you RV support if you need it. If you don't need it, you don't need it.
Right.
I mean, but it gives you that additional RV support that if you need some time. And you can ambulate with it. So what's your thoughts about that?
To be honest with you, I don't have much experience with it, so I'm going to defer to. I'm just going to listen to what you have to say, and
It is basically placed through the neck.
right.
I mean, fluoro mainly. You don't have to worry about the little hole on the front of the tricuspid. But for me, I enjoyed playing with that on TE. I love TE. So seeing the flow there, for me was like, and I know it's a little nerdy, but it was like very amazing to me see that flow around it. That we got in the right place. But what happens is we move the patient, go to the ICU, then the PO2 goes down, and you have seen that. You move the patient with Avalon, you go to the ICU, PO2 goes down. Why? Because it moved.
Wait till you hear my talk today, because I could not disagree with you more.
I know, that's why I'm pushing you over the edge. I'm surprised you're very restrained. You must have had CBD this morning. So it's really, for me, it's like putting an Avalon with the advantage of RV support.
Okay.
That's how, I make it a little simplistic, probably yes. But, and then gets the advantage of ambulating and neck placement, what we want to do with the neck, ambulation, people not laying in bed, you agree?
Absolutely.
Yeah.
So before you go on, because I have to work with this guy over there, okay? And I don't need him going, oh, we got to get this Protect Duo because Dr. Samir said we have to have it. So,
Well, I
there's-
am almost 50, so it's a little harder to get me to change some things too.
Good. I'm glad to
Oh,
hear
no,
that.
that's not.
So,
That's
You're
leave-
very young, Mark.
That's not giving you carte blanche. I
I
want to listen to
understand.
this.
I understand.
All right.
I understand. And you can
50's
always
the
go
new
back
30.
and you can
Right.
you can actually rewind this. But Tammy, I think you might be. I hope you're on my side here. Okay, I'm counting on you.
Then don't be scared. We'll give you,
So, no, in all seriousness. So, if you think putting an Avalon catheter in is complex, try putting this one in. Now, LivaNova is one of our main sponsors, so I'm gonna go really out on a limb here. Now, they bought Tandem. They bought this from Cardiac Assist or whatever the name of that company was. They called it the Protect Duo. So, I think it's great for RV support. I think it's a lot better than a right-sided Impella. I think it's actually easier to get in than a right-sided Impella.
does not work.
And I think that the Impella even for LV support is a bit on the finicky side, getting pulled in and coming too far out, and having issues and having your LDH go way up because of all your hemolysis. There's a variety of issues. Now ECMO also has its own downside, but the cannula doesn't have the same, you can't get as much flow, although I recognize your flow is there's a lot less recirculation, if any. If there's probably very little recirculation, if any. So I'll recognize that as a potential advantage. But what we have to also consider is the advantage worth $18,000? You have to be realistic about this. The ECMO circuit that we use, excluding the cannula costs about $2,500. The Avalon, somewhere around there.
It's like
the Crescent,
$2,300.
yeah, the Crescent. All of these prices are coming down because they have Origin, they have other ones that are going to be coming out, and I think you're going to see those prices go down. But our entire ECMO circuit, including the cannula, is plus or minus $3,000. Everything. It's $18,000 for the Tandem, this one here, and the oxygenator has no heat exchanger, and they will not sell, in Canada they will, but they will not sell the Protect Duo catheter separately. They will in Canada and in Europe, but they will not here in the United States. But even in Canada, it's $11,000 for just the catheter.
I agree with you on all the pricing and everything. I agree 100%. But I have to look at a different side. I have to look at The poor RV has nothing to support it.
But if the RV's not compromised, if the patient's 36 years old and they have ARDS and they don't have they have no reason to have right heart failure. I mean, I can't tell you the last time I had a patient that Dr. Matoyer cannulated that had primary, lung failure secondary to some inflammatory process, ARDS, whatever it was, aspiration, whatever the situation was, that had no reason to have cardiac dysfunction. They never developed right-sided failure. I mean, I cannot remember
Never is a
any.
big word. Never is a very big word.
Okay, I have not had that experience. I have never had that experience. I can say that.
Let me, intuitively it sounds great. You are getting deoxygenated blood from the atrium, right atrium, or the SVC or IVC, wherever it is, and you're directly pumping it into the pulmonary artery.
Sure.
You're taking out the RV out of the equation, valvular reflux, tricuspid reflux, and everything. Very intuitive. But the practical aspects of it, one, you have a huge cannula sitting in the RA and the RV.
Well, you probably have more risk of tricuspid insufficiency because with the Avalon, it doesn't
Absolutely.
go through the
Go through it.
tricuspid.
That's
This
right.
does and takes a big turn.
Yes.
So 2 valves are going to be compromised.
So I cannot think of a scenario where you're talking to me about that you have significant RV dysfunction where you're just bypassing or supporting the RV, you're going to improve the oxygenation or the cardiac output, because we are talking about something very different. It's a very unique situation where it would be just the RV is affected and everything else is fine. I don't think it's selection on it. If you ask me, the Avalon downside always has been that risk where you are essentially creating a loop and you have a lot of, and sometimes it can be very challenging. Anatomy is different, humans are different, some people have different ways of approaching it. That was the downside of using an Avalon, but I still think Protec wanted to go beyond it, but I don't know whether it's safe actually to go through the RV and put it. It would be very selected patients where you can face that scenario.
To be honest with you, I'll tell you, Jitol, I see how people go down from the RV and you keep flogging it after that. Hypoxia, that causes cardiac dysfunction. And the problem with there's nothing to support the RV. And you already went through the exercise of going to the OR, putting the cannula and all that. And you already have the patient on ECMO. So get the best bang for your buck for the patient. That's my idea.
Gotcha.
Avalon has done well for years and years and years.
Absolutely.
But it had that idea. The problem is you go to the ICU, all of a sudden PO2 was like 400 in the OR, comes back into exactly.
I have a
It
solution.
moved and everything, yes.
I have a solution.
Then they're calling you again. You have to take the patient back again to the OR to rotate and fix. This, it's.
Man, I tell you, I can fix it in the ICU.
Again,
I will have to tell you, Mark, you're really great, but not everybody.
I know.
Dr. Samir, also your comment about the Avalon being, it's very operator dependent. This is even more operator dependent. This is much trickier.
Once you get it in the right place, Tammy, once you get it in the right place,
It's
you cannot
not gonna move.
Yeah. And see, it is a curve for the surgeon to put it in the right place. Okay? You have to think about it as a swan and to put it in the right place. It's a curve, a learning curve. Nobody first day is going to be able to go
Right.
do it.
But again, my view is lacking RV failure. And even if you have RV failure or heart failure, just, RV, cardiac failure, and you did this, of course, we had this discussion before. If your heart dysfunction is secondary to hypoxemia, and even if you just put 2 cannulas in and just improve their oxygenation at all, their cardiac function gets better. So why do we want to use something to support an RV that is not failed? In RV failure, I agree with you 150,000%. Couldn't agree with you more. For non-cardiac associated hypoxemia from lung dysfunction, I can't say that I think it's a wise decision.
I think it's again, I want to pitch in. I think it's a bias because working in 2 different institutes like St. Luke's and Methodist, and then moving to Memorial Hermann, which were all was based on cardiothoracic surgery and the post outcome. I mean, if you look at PAH, which is the most common RV failure, which we see, one of the first things which you do when you are facing with RV failure, where you require some sort of pressor or inotrope to support the patient, is control the usual things: infection, hypoxia. If you supplement there or improve their oxygenation, that should improve putatively the RV failure itself. It's very rare a scenario. Can people live with RV failure? Yes, we don't even list patients unless their cardiac index is less than 2. People go with maximal therapy, they live for years. Nowadays, the therapies are so effective, people can even live with 1.8 or 1.5 and they go on to into the 60s and 70s. It's just a functional. On the hypoxia aspect, even before transplant came into board, people used to create a shunt, essentially a right to left atrial shunt, essentially. So a PFO, or if they didn't have it, they would open it up. Excellent literature. These people live in the 80s. They're purple, but they live long because the RV has been decompressed. But again, I'm talking about a severe illness. It's because I face the same situation when I tell people this is a totally different ball game from, say, ischemic cardiomyopathy or non-ischemic cardiomyopathy or post-cardiotomy RV failure. This is a totally different ball game which we are talking about. This is not secondary to the LV failure or whatever the consequences is. This is, we are talking about the right side and the lung which is injured. I think in that case, I think Avalon is a good enough device in that scenario. I think it would be extremely rare where I want to bypass or the RV is so failed that I need to support it. If that's the case, probably VA is a better option rather than just going for a PROTAC. That's just like twiddling your thumbs and seeing what exactly is happening. That's my take.
So
I don't know.
Okay, and this is trying to give Dr. Samir
Lifeline?
a little bit of a lifeline.
Oh boy. Oh, please don't.
Oh no!
Please don't.
I'm
you have-
successful agitating Joe today. I'm succeeded today.
Not that you needed any help defending yourself. So, I'm right there with you 100%. Offloading the RV, supporting with VA. The morbidly obese or super morbidly obese, or just the 6'7", 350 pound, even pseudo healthy guy, when you're not going to flow enough, and you're going to you worry about Harlequin syndrome. Does this change your mind a little bit about using this?
But that's a very good question. Again, we are talking about what the actual cardiac output is. We know that
Correct.
if you're morbidly obese, your cardiac output is going to be very high.
Right.
I don't know, ProtectDuo, can you flow higher than the biggest Avalon? I'm not sure. I don't know those technical.
I think you're going
gonna get
to
about 3
basically
liters.
what I'm saying is, does it provide an adjunctive role in some way?
That scenarios.
It's not a sole role.
No.
is what I'm
right.
saying.
No, and I think that if you're using it on a patient like that, I think we have to become more comfortable with exotic cannulations, which you really don't do much of. But I think in those patients, like let's say an Avalon and a ProtecDuo, both simultaneously, or a second access to be able to increase the flow. With the ProtecDuo, you can't because the outflow is going to be restricted, but you would want more. You would want to have more outflow. If you're using an Avalon, you can add another outflow because you have that to take the higher flow. So I think we need to get more comfortable with exotic, even with VA. When you have fem cannulation and you're worried about differential hypoxemia, you can go ahead and put a line into the right IJ, just a regular opti, drop it into the right atrium, and it will probably be enough to at least give you a sustainable saturation in the top part, and the circulatory support that you get from the fem. That's what I think.
You mean more holes, more bleeding? I get it now. I got it.
Again, my view on it.
That's my philosophy on heart surgery. The more places you put in the heart, the more places you have to bleed.
Yes, that's true.
I don't use an superior pulmonary vein vent. I don't do retrograde on everybody.
I agree. I mean, the more.
So no, I hear you on that.
Like, do you need to really
I don't
repair
even
the PFO?
I don't even stitch I just have one stitch on these now because the stitches that you put in on the thighs and the shoulders and the chest, they all bleed.
Everything bleeds.
It's just it's awful. So yeah, I agree with that part. I'm just throwing that out there.
I do want to say something, though, if I may. And I think this also goes to what you were what I hear people talking about when they say, ambulating the ECMO patient, the VV ECMO patient. Much in the same way we're talking about this, is that with RV failure, it's a big difference whether it is an acute problem
Absolutely.
or
Absolutely.
a chronic
Absolutely.
adapted problem. So if you have an acute RV failure from an infarct or something like that, they don't do well at all. Even though it's
Yep.
adaptable,
Yep.
if it slowly is a progressive disease.
Absolutely.
And the same thing with these patients that are, if they're a lung transplant patient, and you're basically bridging them so that you can keep them conditioned for lung transplant surgery.
That's right.
Yeah, they walk around the hospital. But if they come in with an acute illness and a sudden compromised pulmonary
They're not gonna be able to
function,
walk anyway.
they're not going anywhere.
That's
They're
right.
really sick and they don't
That's
feel good, and they want to be very asleep and paralyzed, and that's it.
And I'll throw this other scenario out there for you. Aortic valve, you either, and it's not just you're worried about the annulus covering up the right coronary, getting acute right heart failure. I think it actually is because if you put one maybe that's in a little too big, you stretch it and it makes it a slit.
Distorted.
Distorts it, or for whatever reason, you got a short right coronary and now it's tilted up more and it's coming down more at an acute angle. You can't figure out what's wrong. You had flow, now you don't have flow. That may be an option because that is acute right heart failure, isolated acute right heart failure.
That's right.
And then,
SVG to the RCA.
well, but that's, I'm just throwing that out there to kind of bail you out until you can.
Yes.
Calm things down and
Agreed.
evaluate the
In
situation.
that case, you're right.
Right, because, I mean,
would be a
it-
perfect choice.
Here's also my philosophy on heart surgery. If you've got a normal ventricle and it's pretty routine and you're coming off and you can't come off, it's something you've done.
That's right.
The
Absolutely.
surgeon. And I'm telling you, surgeons that don't believe that, they're out of their mind.
Yeah. That's,
You've tied, you've
You know it's the perfusionist's fault.
Absolutely.
And we know
No
it's
question about
anesthesia's
it.
fault,
it's
right,
anesthesia's
it's always
fault.
anesthesia's fault.
Yes.
ultimately.
But again, you rightly pointed out it's a scenario like somebody comes in with a massive P. Whatever reason is RVE is not tolerating it. Yeah, the clot got lysed or something, but they're still struggling. Yeah, maybe in that scenario, it's an excellent option to use as a transient support.
I think so.
Yeah.
Or
But-
just VA ECMO.
But you've,
Okay.
so maybe you screwed around long enough and you finally did the SVG to RCA and now it's taking its hit.
There you go.
And now
You're
you got a
stunned.
long-term
You're
problem.
stunned, yeah.
Right.
Yeah.
Right. I would not want to put that person on VA ECMO.
No.
Or
Good point.
VV with Impella or
Yeah.
whatever. I mean,
All
that's
If you have good left heart function, there's no need to.
Right.
Yeah, so-
But I'm just
Yeah.
talking about pure offloading. That's
Yeah,
it. Yeah.
yes.
And then they get into the problems of it having a normal left ventricle competing against you. So I mean, there's it has its role, but
Agreed.
But I agree, cost is a problem and
Yeah.
It's a huge
Yeah,
problem.
it's
And, you know,
technical
it's,
technical.
Technical expertise, because how often are you going to get the skills to if you're not using it very often, you're not getting the practice.
I'll tell you
And
something. If Mark is doing Avalon that good, he will be able to protect.
I'm not. It doesn't. I'm getting. You know,
Oh.
we're using the angiovac and tying a suture to the end and flipping it into the pulmonary artery. I
You don't
mean,
have to anymore.
I know. But I'm just talking about we can. Yeah.
The old
it's-
days.
It, if you know your anatomy and you think of it as 3D and not 2D, you know, it's not right to left. It's actually posterior to anterior.
You're flipping it over, yeah. Flipping it over itself.
It's,
It's a good point.
but anyway.
So here's a little just a picture about the Avalon, and this is just for you, Tammy, just because here is my risk for Avalon, and unfortunately I've seen this complication. I love this picture because it shows the end of the Avalon, how tapered it is,
Yeah.
and I have seen, I'm not sure you were there at the time or not, open the chest and the Avalon is coming out of the other side. You know, okay, because the sharp tip, okay?
That's a
And
problem.
that is
that's
a problem.
And that happens when you don't use fluoro. When you
So-
use only TEE
I'll tell
because you don't
I
see
have the
it.
issue with the sharp tip because of that, you know. So-
But the Crescent has a more blunted tip.
You have to have fluoro.
You still have to have fluoro. Agreed.
I mean, that's you can get away without TE. You can't get away without fluoro.
Correct. I agree with you.
We all have seen disasters like that.
Yeah.
And here's the other thing: you get the wire in there in the infravena cavity, you bury that thing, and if you're in a hurry, it'll still flip into the RV, an RA. I mean, it's not guaranteed. You
I'll
gotta-
tell you totally anecdotally. I'm sorry to break you in. I was a second-year resident. So my senior resident, he's actually a very renowned intervention cardiologist right now, placed a line on a patient. Even I knew it, like I was a night call intern, the nurse calls. She says, line is placed, can we use it? I look at the x-ray and I'm like, this is something really funky about this. This is not the usual coursing in or it went to the other side. It actually landed up in the vertebral artery on the right side. Wow. But things like that. Again, what I'm trying to say, yeah, operator dependency is operator dependency. You know,
Okay.
We're
things
looking
like
at
that
the
happen.
Avalon placement, you know. I mean, it really does. I mean, I think both need a high level of skill. With the Avalon, you have to be man enough to do these dilations. And I'll tell you, when I watch some of these dilations, I'm scared. So,
Good 11 blade cut, good spring hemostat.
Generous surgical exposure.
But the smaller people, yeah, you're right. I mean, that's
Babies.
just the thoracic inlet
Well,
is
did you
tough.
see this? Did you see that incision he just made? for
Yeah, you just,
I mean,
Just-
who you don't do that.
that's a huge incision actually.
Yeah, I make the incision big enough to get the first one in,
It's
and
a
then I
wonder
use a
this patient
and then I use a
bleeds.
hemostat, and you can control how big. I mean,
Yeah.
that's pretty aggressive.
I mean, you want to know why this patient's bleeding?
Now you know.
Who's
I like to
doing
make
that?
it. Yeah,
Is this a
it
vet?
just comes. It comes with.
Veterinarian?
It
This
comes
is somebody we
orthopedic
don't know.
surgeon.
This is from
It
YouTube.
comes with
He's gonna
YouTube.
find you later.
experience.
Yes.
I mean, that's all it does. It comes with experience.
That's right.
Absolutely.
I mean, look at that hole. You
I
can
mean, I
drive
don't
a
use
truck
all the
through it.
dilators.
Gotcha.
I use the first dilator just to get the hole started in the IJ. I do one in the middle, and I do the last one right before the size of the cannula.
And what's so amazing about that is that after
Because
the
every time you
patient-
do that, you may turn the wire into the RA.
Yeah, exactly. Good point.
That's right. That's a
I'm
good
limiting my fluoro time too, but I mean, it's just, I'm always kind of in a hurry, but my point is, why waste a step? I don't need to serially dilate 7 times to get it up to where I need it.
That's because you got trained by Dr. Cooley. Why waste a step?
Right, exactly.
That's the whole- that's why he was as good as he
He didn't
was.
move fast, but he was done with a heart in hour and 45 minutes, skin to
Yeah.
skin, you know.
Yeah, it's
3
amazing.
vessels, yeah.
But yeah, and then you pull this big giant tube out after the patient does well, and you reverse their anticoagulation, or you just turn it off. Don't even hold pressure. You just close the skin,
Just tie
and
the
it
stitch.
doesn't bleed.
Yeah.
It's amazing, and it's a huge hole. So nothing to be afraid of, Dr. Smith. It's okay.
As
Oh,
the
trust
video
me, sir.
plays,
I've
the
been with
blood
enough lung
condition.
transplants. We're putting the Avalon out under the drapes and holding pressure, or like with just like tying the suture. I'm going to mention it with my great buddy, Dr. Scott Shinen. And we had fun together doing this case like that. So he told us laughing. He remembers those days.
Oh, Lordy.
So now, one little controversial question I have for you, Jatola, while this video is playing.
Okay, first, I already see a huge mistake.
What is that?
It's YouTube.
Huge
Can you give them
mistake.
a
Oh,
call?
come on. You
Call
cannot be so-
YouTube. Give them a
mistake.
call.
Huge mistake that he tied that, he secured the cannula too soon. And I'm going to show you why. See, I'm plugging myself here because
Oh
I've got
my
a really
God.
good talk. If I can ever get to it today, before we run out of time, your hamburger is almost, it's going to be
Well, doesn't-
extremely well done.
Oh,
Well, you're interrupting us, sir.
He's being a perfectionist.
So, Jatola, I have a question for you. So now, going back to ethics, so about like THC and all that, do you think people who vaped should be listed or not? In a personal opinion, not a company opinion.
The company opinion, my own opinion.
Yeah, your own personal opinion.
We live in the United States. We love a good story of redemption. Absolutely. I think we should.
I agree with you 100%.
Mark?
I
Yeah,
do.
I do too.
I agree with you 100%. Now, I think
Everybody
if you
should be given a
have
chance.
lung
Especially now. I mean,
transplant-
Especially if it's
especially
a
right
kid.
now at this
Yeah.
stage. I mean, this is not like where people didn't believe that smoking caused lung cancer until Alton Auctioner brings it up,
Yeah,
and
in the
then it takes
50s.
50 years for people to start buying
that's
into
right.
it.
Yeah.
Yeah.
You know, only from my neck of the woods do people still not believe that. They think it's smoking an herb and it's good for you. You know, kind of like marijuana or whatever. But it's the education's just not out there. They think it's safe. You know, that and it's, you know, it's. I agree. I think that would be playing a little bit too much like God. You know.
Now, if you have a lung transplant, but you continue to vape,
Oh, yeah.
and
That's
your
different.
graft
That's different.
fails,
Oh no. Well, yeah.
Game
that's-
It's
over.
a different story.
Yeah, different
I
Oh,
mean,
we have all seen that.
I
Again,
mean-
it's
There's all kinds of reasons.
get second
and
chances.
Things
It's-
that you
yeah.
can be
you
non-compliant.
get
the re-
one
the-
second chance.
until you can start growing them. You know, that's
Yeah.
you know.
oh yeah. I hope that comes through.
Hope for you, TMB.
It's not going to be in my lifetime, I'm afraid.
So now,
Or I could live
That's-
forever. Wouldn't that be great?
No.
not sure that's a good idea, but anyway.
Okay.
Okay, so now we're talking why we went on next strategy, because walking those patients, if it's acute and we can get them walking, we can rehab them, get them ready for a lung transplant sooner than later. I mean, anybody, I have to tell you, it does not matter what disease you have, you need to get out and walk if you can do it safely. And obviously, femoral cannulation, people are walking patients with femoral cannulations, but I don't think that's a
I
good.
think that's crazy.
But it's happening. I looked at it
Really?
with Chris. I was talking with Chris Prem even. People are walking, but is that really safe? But I think with
No.
femoral, I think with
Femoral cancer.
I'm telling you, with Chris,
Well,
and Chris
step
will be on
on
this
that.
program. Yeah.
Well, even just the mechanism of walking, you're bending your leg.
I'm telling you, one of our most amazing physical therapists, we looked at it together just a couple of days ago. People are doing it.
Now, are you sure they weren't gymnasts and they were walking on their hands?
Okay.
Are you sure?
Yeah, I'm not sure about it.
Okay, so anyway, we're trying to walk patients to get them, rehab them, get them ready to. I mean, the stronger you are, the you're able to get extubated or get out of the hospital, or
It's not the
get
only-
transplanted.
It's not the only reason. I've walked in on one of your patients. If you remember, you were getting called because they were whining and complaining and crying about the saturation being still very low, and they wanted you to go in. And I went in there, and they had this patient, big, giant patient with a big, giant belly. I mean, it was
Lord.
the ultimate crawfish graveyard. All right, and they're laying just flat.
Oh boy.
And that big belly just pushing up on the diaphragm. That patient's lung space was about, thoracic cavity was about this big. Took the patient and sat them up 40 degrees, and the saturation goes bloop, 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 all the way back up
Yeah.
to where you want it to be. And
Absolutely.
crisis averted.
Yep.
And people forget about that. That's what's the disadvantage. If you have them in the groin, you aren't doing that because you're going to kink your cannulas, you're going to have problems.
And what our barriers for walking a patient is decannulation, which unfortunately I have seen. I'm sure Jatola has seen too. And the problem was, with we're gonna like say, when your pump is on, you decannulate it. The pump is like a snake. The cannula is all over, blood is being sprayed all over the room.
We know.
And it becomes an ugly scene on the nurses, on the staff, the patient. It's like I would say, somebody come and shoot the patient. So
You don't have to. It doesn't take long.
So-
They lose consciousness very fast with an acute decannulation.
But I'll tell you something from my experience. I work with an amazing team that walk the patient safely, and they have this nice. I told them the tennis headbands, and they all come in different colors and themes. Patients put them around their cannula. Everybody's watching them. Perfusion is paying attention. Physical therapy, perfusion, and a nurse and a PA to assist walking. And really, I have to tell you, the special walkers for that, and we haven't had any issues. The ones that got decannulated were laying in bed thrashing around. And obviously, like Joe said, you have to look at the risk. This just had an acute event where somebody who's been on ECMO for a month, or his heart is not working on epi, nor epi, and a balloon pump. You're not gonna walk that. I don't think so.
No. Now you could do some, physical therapy in the bed. You could
Range
do
of
some
motion
range of
and things.
motion
Yeah.
stuff. I mean, there's things you can do. You can have
That's right.
them doing a little bit of exercise as long as they can move their legs. And again, that's one of the big reasons why you want the cannula in the neck, not in the groin, except for rescue circumstances.
And here, just showing a process of walking an ECMO patient. It does take a lot of people, a lot of help, a lot of equipment, and support from the physicians. The biggest barrier to walking is physicians sometimes don't believe it can be done safely.
Yeah.
But I know Jatola was a big champion for ambulation, and I'm sure Mark is.
Absolutely,
yeah,
you should. There's no reason you should be bedbound.
Exactly. So, I mean, it does take a lot of people, but that little walking that you guys think is very little, it's a lot for those patients. It takes a lot of effort to do it, but it helps get things going. That goes about early ECMO, no muscle relaxants, and you're laying down in bed with steroids, and the comorbidity of that. And then just everybody has to pay attention and be like aware of their surroundings. The neck cannulation, the ECMO, and everybody's looking at everything and the team talking to each other. And it can make it a recipe for success.
And you rightly nailed it. It requires a team to it. And as I tell all my patients, even my own nurses and nurse practitioners, everything, yeah, I have like probably a max of a 20-minute encounter or a 30-minute encounter, but there's still 24 hours rest on the day. And you need a whole team to make that happen. And I think it makes the patient more looking forward. There is a big, powerful message. Hey, you know what? You're sick, but we still want you to walk and see, lead whatever sense of normalcy we can do. I think that's huge. And it's, I think, great for the staff, too, to realize that, hey, we are making something proactive out there. I think I totally agree with you that it requires a team to do it, buy into the
I
philosophy.
think it creates positive attitude for everybody.
Absolutely. Yep.
You have no
It's
idea. Those
supposed to be
patients,
a
when they
provider's
walk by the window and
invitation.
see the sunlight, that for them it's something like huge. They haven't seen sunlight in days and years.
Yep.
You know,
That's
and
right.
now all of a sudden they see sunlight, they feel like there's hope in life.
Yes. Yeah, good point.
It's a big positive reinforcement, absolutely.
So it's not just physical; it's psychological also.
Yep.
Next.
Is the next one. No, it's just bad.
I think we
I think we've done it.
really
done that.
seriously.
You know, you wanted comprehensive VV. I give you comprehensive VV.
Okay, that was very good. I thought that was
Yeah.
very, very good discussion back and forth.
Thank you, sir.
No protect you.
I'm gonna I'm gonna take a vote from the audience. Okay, we got some high-powered healthcare professionals here, and from the anchor desk here. Who all agrees with me, and who all agrees with Dr. Samir? We're gonna do it by.
Don't be scared, all of you that
We're
were in
gonna do
his
it by
house.
applause. See who's the loudest. Okay, so Dr. Samir will go
Loud with this
first.
one.
Who agrees with Dr. Samir? That really hurts. Who agrees with me? It's a tie.
It's a tie.
It's a tie.
It's a tie. That's
In
very
my
good.
ear, that was a tie.
Gotcha.
Sure, whatever you say. Okay.
Okay. All right. So, can you hang around and see this? I want to show you something.
Yeah.
Very important. If you can, if you don't mind.
We haven't gotten the blood gas back yet, so
Okay. Good. Do we need to go put an ECMO in?
maybe.
I've got one. Okay. So,
All right,
go ahead
I'll
and
be
throw
first.
my slides
Oh.
up. Dr. Samir, thank you. That was excellent. I really
Anytime.
enjoyed that. I really did. That was good. Okay, so what we're going to talk about here, let me have the clicker. Recirculation is a vital sign indicator for VV ECMO patients. Now, my disclosures is I have no financial conflicts of interest, but these slides were generously shared by Transonic. I moved them around and did other things with a couple of slide decks to create this one that we're going to look at here today. It's obviously VV ECMO is for primary respiratory failure. If you're using just pure VV ECMO, not the Protect Duo going to pulmonary artery, bypassing the RV, but just you have a hypoxic problem. You can also use it for CO2 removal, but I'm really wanting to talk about an oxygenation problem here. And this is typically what we see with ARDS, secondary to influenza, pneumonia, the acute phase kind of patient. Most of these patients are young. We talked about it earlier. And so they have a high degree of viability if you get to them soon enough. But it's one thing to get to the patient soon enough. It's another thing to have an effective therapy. And the big problem that we have is that recirculation is an enormous problem that is poorly both understood and even more poorly addressed because most people don't really know exactly how to address it. You make a change and you see a change, but it doesn't endure. And what is there that we have to objectively measure the optimal placement of either dual cannulation for VV or single dual chamber cannulation or double lumen cannula, single in the neck, like the Avalon catheter or the Crescent catheter. So here are the basic cannulation strategies. You have two venous cannulas in the groin. One is the access is put in short. The return is put in longer from the contralateral femoral vein, and it lives in the right atrium. And that way you're taking advantage of the natural flow pattern in the venous system. The blood is going from the legs to the heart. So your recirculation in this scenario is probably less. It's a better alternative to the second one, which was very common for the longest period of time, where you have a femoral venous access that's pushed up to the high IVC, and then you have the return in the right IJ, placed usually just in the SVC, but that's going to have a very high degree of recirculation. I'll show you some of that, and then you have that single cannula. So let's explore first this one, which if you look at the schematic to the right, you easily see the access, you see the return on the top, And it's easy to understand or to visualize in your mind that if the blood is coming out of that SVC cannula, the top cannula, at 5 liters, and it's pulling at 5 liters from down below, that you will have a jetting just straight across from one to the other and really minimize your therapeutic value or therapeutic efficiency. And this is what it looks like on X-ray, and you can see the 2 tips of the cannula there labeled. And those lung fields look pretty bad. This patient probably really needs to be on ECMO. But this ECMO strategy, though easy to do, doesn't have very much efficiency associated with it. It can have poor efficiency. This is the 2 venous cannulas in the groin, one lower to the one higher. You have less recirculation, but you still have recirculation, as you can see from the diagram there on the right, just diagrammatically representing what I'm referring to. And then you have the single, that's the same thing, that's just a drawing. And here's the radiograph you see on the left, and you can see the 2 cannulas, one further up than the other. The one coming from the left groin is going all the way up to the atrium, and the right groin, it's much lower, and you can see that on the X-ray from the outline. And then you have this technique. Now, theoretically with this technique, you're going to have very minimal recirculation, but the way it's drawn out on there is not necessarily representative of everybody's anatomy. The superior vena cava in one person could be longer or shorter than the next. The size of the right atrium, the depth of it, how far down the IVC is, all of these things play a major role. So you can have the tip in the inferior vena cava. It doesn't mean that your access is actually in the SVC. It could actually be in the high right atrium, and your return, instead of being in this optimal position going through the tricuspid valve, pointing towards it, all of that kind of stuff, may not be doing that and very low, and a lot of your flow is being forced down into the IVC and thus also in the return part of the cannula. So this is a big problem. But this is what it looks like, you know, on X-ray with the heart sort of drawn out for you. But you can appreciate easily where you see the SVC, how easy that would actually be to have it in the right atrium versus in the SVC, and that IVC would still be, you know, of course, it's down in the IVC. I'm happy I've put it in as far as I need to. But it's only a centimeter is going to make the difference between effective flow and not effective flow because it's in too deep. How can we tell that? And we have all kinds of surrogates for it, and I'll discuss that. But here are some of the McKay double lumen or dual lumen, which used to be Avalon made it. We still call it the Avalon, but McKay bought Avalon. And then you have the second generation, the Elite. You have this Origin. I don't know anybody that's used the Origin. I was asked the other day. Has anybody here ever used it? Okay, but it does exist. And then you have the Covidian dual lumen, which is the Crescent. So that's actually Medtronic's version or iteration. And I know a lot of people in Florida doing big time ECMO cases, but they have 8, 10 ECMOs going all the time around the clock. 7 days a week, 365 a year, and they're putting this Crescent in through the left subclavian and then dropping it down. So they're putting it in here and putting it down into the IVC from that direction and having very good results with it.
So what are the advantages or disadvantages of each of the catheters?
So the advantages, I think the only real advantage with the Crescent is that it has a little bit different shape to it, which theoretically makes it easier to put in and to maintain both its shape and position. And it has a little bit better internal lumen diameter than does the Avalon. I don't really think there's a huge difference between the two.
Are the flow patterns different, or if the diameter is higher?
I think because the internal diameter is a little bigger, for the same size cannula, you get a little bit better flow. But to be frank with you, I have never had, I mean, if you use a 27 or a 31 and you use the corresponding Medtronic, you're not going to put a 27 in and get the flow of a 31. It's going to maybe be a 28 versus a 27
Gotcha.
or a 28.5. I don't think it's really going to help that much. But what are some of the cues that we use? Well, when a patient's arterial saturation is going down while we're on VV ECMO, but the pre-oxygenator saturation is going up, that is a surrogate for us to say we have recirculation. But we don't know how much, number one, and number two, there's a host of reasons that your access or your venous saturation can go up. It can be oxygen delivery has gone up. It can be oxygen extraction rate is down. It can be, all kinds of reasons.
Absolutely.
Temperature could have changed. So yes, it's a good surrogate when you have nothing, but it can be very misleading and cause you to do something that you really didn't need to do. Your reason for your problem may not actually be that, but it's masking the real problem because that's the easy solution. And so I don't necessarily think it's a really good thing. And then, of course, what do we do when the saturation goes down? We turn the pump flow up. And what you see in this diagram is as your flow goes up, which is the linear line, the straight line, the amount of recirculation and effective flow, the recirculation increases, but your effective flow decreases. So and if you keep going up, it just gets worse and worse and worse. So turning your flow up when you have a recirculation problem, though it's intuitive, is counterintuitive to is intuitive but the wrong maneuver.
That's right.
So that's the problem. So here's my scenario. I'm going to ask all of you what you would do. Patient gets an Avalon catheter put in or a Crescent catheter put in, and you put them on VV ECMO in the operating room, and they were on max vent support. They were on all kinds of drips, and you put the cannula in and you turn the ECMO on, and miraculously everything just gets better. They're sat in 100%, the drips are getting cut back, everybody's excited and high-fiving, and we save the patient and it's great. And now we take the patient to the ICU.
Honeymoon period. That's what I always tell the families.
That's a thought.
Every
That's a
time.
thought, but I've got that plus. You get the patient to the ICU. And now what does every pulmonologist want to do? You
Turn
want to
down the-
protect the lungs,
That's
right?
right.
So what do?
Turn down the peak.
Turn down the PEEP bottom.
Turn down the FiO2,
Low tidal
you turn down
volume.
the tidal volume.
That's right.
And all of a sudden, your saturation is 78, 80, 88, maybe 90. It ain't 100 anymore.
Fast.
And you're not happy. Let's say it's 86.
I think
and
it's
you're
you
like,
moving the cannula, Joe.
what happened?
Exactly.
Yeah, what happened? Now, anybody that can tell me what happened, because both Stephanie and Tammy both owe me dinner at Trulux. I will donate one of my dinners to Trulux if anyone here, just one of them though, Stephanie's, not yours, why the saturation's down. Why? Why did it happen?
The low-lying fruit that the cannulas moved during the transportation.
Cannula
No,
didn't
it's
move.
nothing to do with the
Cannulas
cannula.
absolutely 100% didn't move even a nanometer. Good. I'm going to keep my 2 dinners at Trulux. Perfect. What happened was you put the patient on ECMO under the general anesthesia. The SAT got better with maximum ventilatory support because the anesthesia never changed it. Now you get them to the unit and you have new ventilator orders, and those new ventilator orders is not enough for the lung to supplement anything. There's nothing now,
Got it.
as opposed to there was something. The problem is the cannula was secured in a suboptimal position. I'm going to show you that too.
Okay.
So I saved my dinner to Trulux. Now I still have 2.
So you're essentially telling the
won the bet.
oxygen requirement
You
was not
did.
so high, so probably was paralyzed and everything. So
They were that. You could still have them paralyzed. What happens is you have a patient who their lung function is so poor that they cannot, that it's not life sustainable, but they still have some recruitable oxygenation from their lung. But when you take that away, the ECMO, because of the recirculation problem, is now not enough. So what started off as a high five is now having to call him and say, we
that's
think
pretty
the
common.
cannula's not in a good spot. It's pretty common. But there's a solution to this. And I discovered this. And the next ECMO that we get, in fact, we were going to put one in the other day. It was 11:30 at night. I had everything packed in the car. I was ready to go. Because this
Well,
is
it's going to be one in an hour, so.
this is good. Well, we're going to come do it. This is some real serious stuff. Okay, so this is the device. It is made by Transonic. I don't make any money from this. I'm not advertising for them. It just happens to be a device that exists that I think we have to have. In fact, I think we have to have it so much, we have one as a practice. I think this is essential. So what this does is, if you look here, you basically take this device, you put these probes, and by the way, this is FDA approved. It's been validated. I have an abstract that was done in 1995 on this technology and why this was happening. It was actually used, interestingly enough, and I'll show you, for your dialysis access. That's how this whole technology started, and they actually have it so that you can predict whether or not whether your fistula or your graft is going to go down. It can give you predictive value, and they have it. But it's not even that expensive. But dialysis clinics don't want to buy it because they don't want to spend the money for it. But it would be tremendously helpful to any surgeon that does dialysis access to know that graft is showing signs of distal runoff reduction. And you would know in advance that you were having a problem before it became a crisis. We don't have access and we need it for a chronic dialysis patient. So you give a single bolus of saline. So here's a little diagram, you see the saline going through, it comes up. It's a 20 cc bolus of saline for an adult. It goes through the first probe and you see the graph come up, and then the speed in which that comes back and is seen by the second probe is what determines the percentage of recirculation. So as we go here, you can see on the bottom right that you have 41% recirculation. Your flow, or your return flow, is 3,600 cc's, 3.6 liters, but your effective flow is only 2.1 or 2.2, somewhere between there, liters. That's a major, it's 41%. That's a huge difference that needs to be fixed. So here's what I was talking about. You see the recirculation there. That type of cannulation technique, though it was popular for a long time back in the day, is really very ineffective. This was introduced by Kravitsky in 1995 in Asayo. It's had more than 200 papers in the hemodialysis, ICU, and ECMO fields. The measurements are very simple to do. One saline bolus, it takes 1 minute, and you get this information. And it's ultrasound velocity. Don't ask me what the engineering and the science and all of that is for this thing. I know the information that it's going to give me. We have to find somebody a lot smarter than me. Here's the paper, or the abstract that was presented at Asayo. If you care to look it up, you can find it, or you can call me, send me an email, and I'll send you a copy of it. But this device has yet an additional, and I want to show you the device. Here, let me just grab it. I can get it. I'll probably get it faster than them. This is the device. I don't have the probes are in the other room, but it's small, portable. Here, I'll hand it to you. It's small, portable, very easy to use, stores the patient's information so you can see trends and all of that kind of stuff. But it does something really unique, and something that I think we've really lost sight of as well. So, how many people, now, a square oxygenator is a horrible idea. whoever came up with I mean, could you imagine a square blood vessel? Okay, God was smarter than this. But nevertheless, that does exist. Now, this can happen to any lung, or artificial lung. This can happen to any one, recognizing that. But square's still pretty dumb. But this is what you see. And we can see it with the circuits that we use as well. And people will do a whole variety of things. They'll use pressure monitoring, which when you're measuring pressures pre and post oxygenator, now you have two sources by which very bad things can happen. The more things you have stuck in something, just like the tubes you're putting in, the more opportunity there is for infection, failure, massive blood loss, all kinds of bad things can happen. But this is what it looks like. They take flashlights and they stick it in there and they use these pressures and look at the delta P across the lung and all of this kind of stuff. Interestingly enough, you can have up to 60% of your lung surface area compromised completely before you will see any appreciable increase in your delta P across the lung. And that's a huge amount. But there's a more sinister problem associated with it because that seems problematic. But what's the real problem is that's what that lung actually looks like inside. You can shine flashlights in that other thing. I'll go back to it. You can shine flashlights in there all day long. You might see a little speck here and there and go, there's a little speck. I see something. But then you come back the next day and it's gone. Where'd it go? I know where it went to. This is VA ECMO also, so downstream. Or it's going upstream, going to the lung, your VV. That's what it looked like inside. That very same lung, that's what it looked like inside. Full of clot. And what the clot does is it propagates from the negative, from the pre-membrane side through the membrane, and as it crosses over into the now arterial or distal downflow, it breaks off in little pieces, and you have this constant showering of thromboemboli that you probably don't even recognize. And it's one thing when it's VV and, but it's another thing when it's bad when it's VV. The lungs aren't the world's, how many times have you heard people say the lungs are the best filter God ever made?
That's true.
And it's crazy.
That's
You have
right.
a patient with compromised lungs, but we're going to give them all these little PEs.
Yep.
That doesn't make sense. So what this device does as well is as soon as you put the ECMO in, you measure the intra-oxygenator blood volume. And it should match what the MFU or the manufacturer's use
Be your primary.
tells you, right? They tell you what the volume of the oxygenator is. So that's known. It should match, obviously. But each day when you do this, you're able to assess whether or not you are developing thrombus in your oxygenator, if your anticoagulation strategy is good or not, and whether or not we need to consider perhaps changing this. So you get two results. If you're VV ECMO, you're going to be able to get both recirculation and intra-oxygenator blood volume simultaneously, one single injection. And if you're VA ECMO, obviously there's no recirculation, but you can get your intra-oxygenator blood volume, which of course will tell you whether or not you have clot forming, because that's the only thing that it's going to be plugging it up. So both of those I think are very important. And so my belief is that when you put the cannula in, before you secure the cannula, that's why I said I saw that mistake. As soon as you put that Avalon in, you get it where you want it, we get on ECMO, we do a check. If your recirculation is unacceptably high, and I would say anything over 20% would be too much for me. I think 15% would be great, optimal, and I'd be extremely happy with it. But I think that's going to be a clinical judgment call that you're going to have to make. We can give you the information, tell you how we feel. If it's 25%, but we have great flow, they're having a great result from it, and you tell anesthesia to go to vent rest settings before you leave, you could maybe pull it back just a centimeter, and we check it again, and you see your recirculation go from 48% or 38% down to 20%, you're going to feel a lot better about putting your secure sutures in and sending that patient on their way.
So I'm gonna play Dr. Samir, so it gets worse. Now you've
Then push it back.
Okay.
Yeah,
So how
it's
much
not
fluid
what-
how much fluid are we gonna give this patient?
It's only a 20 cc bolus, right?
Yeah, it's 20 cc's.
Oh, okay, all right.
Yeah, it's
I'm
only
just-
20
that's-
cc.
It's one 20 cc
Okay,
injection. It's
all right.
very easy to do. So, with that said, that's my thoughts. I think, I will tell you, and I'll be provocative since I know you like that. I believe, much in the way I believe about TCD, but I think that for the cost and for the potential value, and I think it's more than just potential, I think it's fairly obvious value to me, I think that should be a standard of care. That's what I say. So I'll go around the table. What say you?
I agree with you.
I just was intrigued with it. What's been the practical experience regarding the volume in the oxygenator? Like, what would you say how this time the oxygenator needs to come off?
That's a very good question. I think, and I'd have to find somebody that had more experience with this. There's only a few places right now that are actually using it, but from my perspective, intuitively, I don't want any clot, but I would probably, the risk of changing the circuit versus, especially it was VA, it's pretty high. Sometimes you have to do it, but it's still a risky maneuver. I would probably say, once it gets up to 20, if you see it trending, starts off with 10%, occluded to 15% to 20%, you're going the wrong way. And your anticoagulation strategy is going to have to change. But I think once you get up to about 20%, I think you're running some pretty high risk of distal embolization. So I would change it.
Gotcha.
At that point, that's what I would do. Now, that's just based on, that's not based on me
Anecdotal
having any experience whatsoever with this. I haven't even used the thing. Okay, I just got it.
Gotcha.
It was better than any Christmas present I could have gotten.
Gotcha.
And I just need a chance to use it. But I think it should be a standard of care. What do you think?
I mean, if it improves your capability, I don't know about the recirculation thing. I think that's something very intuitive, which we already realize. But regarding the oxygenator and the clotting, yes, I think that's a good way to look at it, especially in the VA circuit. I don't know much about the VV, but that's my thought.
So I tell you, I think if you get this recirculation, get a cannula in the right place from the first time, don't play around. That's good
But
for
what
the sure
if you
thing.
think you have it in the right place and
Well,
your oxygenation isn't as good as you think it should be, and you're coming up with all kinds of excuses
Well, you know what I'm
for
going to
it.
say, right? My
And
answer
then
to
you
you.
run one of these and it's 48%
Protect Duo?
recirculation.
You got it.
Oh, Lord have mercy.
See,
Oh, my
Oh,
God.
buddy.
unless you're going to put the Protect Duo passed along, it's going to be in the right place for sure. There's no
Do you
question.
think it should be a standard of care, yes or no?
I'm very cautious about using those words standard of care because not every place has the capabilities and the expertise that you guys have. Using a word of standard of care is a very word that you have medical legal phrase. You have to be very worried about using it on. So
I'm not afraid to use it.
Well, I am because I work in quality right now. I know what that word means. So I do want to use the word standard of care, and it's going to be operator dependent. And again, we're
Not
looking
the test. The test isn't operator dependent. I mean, you inject, say, a 20 cc saline bolus. I don't have to do any formulas. I don't have to sit there and like I'm flying a lunar module. I just inject it.
Remember, Joe, we're talking about smaller institutions who do not have all the capabilities. You're adding another layer and difficulty for them.
Yeah, I'd have to use it.
Well, as soon as you're able, let me know because we're going to use it.
Literally, yeah.
And but it is FDA approved, so it's not like
Right.
and I'm not going to charge the hospital anything, but I think this is critically important that we do this.
I think it'll be very interesting once we can use it, get some information from it. It's fairly non-invasive. I mean, it's some probes on the outside.
Yeah, very simple to do.
The clot thing with the flashlight, I mean, that's rudimentary. So
Yeah.
that I agree with. That's something we cannot rely on. That's like,
But it was taught. I was taught
I don't know.
that.
It's still being done. You know that.
Yeah. Since
Yeah.
when does a flashlight see through blood.
I'm not sure.
Unless the crit's, 6. Okay, well then I guess I've seen
little
that.
bit
I've
then,
seen
yeah.
that too. So,
Yeah.
Miss Tracy, since you're the non-clinical medicine person here, and you've heard everybody's kind of argument, you've heard mine. How do you feel as an observer of this? Do you think anyone who's using ECMO should have access and utilize that to document
A lot
their
harder.
cannulation positions?
Don't be scared, Tracy. Just
I'm
Don't
No,
be
I'm
scared
not.
to say no.
Unfortunately, my family's cardiac knowledge it's very familiar with the birth of my nephew being born with pulmonary atresia.
Oh yeah.
No
It's a big
pulmonary
problem.
valve, essentially, and a hole in his heart. So our family's experience is full-on sternum cracking, valve transplant, stenting, that type of thing. And watching the oxygen machines that he had to be on at that time, it was very scary. And I love how you said be blunt with the family, because they weren't always that way with us, because we were dealing with a 3-day-old
Babies.
child and a 9-month-old child. So I think anything that you can do to improve that, in any case where it's appropriate, I think from a family perspective, I think would be greatly appreciated.
Okay, and I appreciate that too. So, I mean, I guess I'll ask the question a different way, even though I think you gave me an answer, but I'm trying to extract from you a more direct soundbite so that I can use it somewhere down the road with Dr. Samir. If
He wants you to be on his
if
side.
this was no, I don't want him to be. I want her to be objective. I want her to be honest. If your husband had to go on ECMO, do you want this test based on what you've learned today, not having all of that other knowledge? Would you prefer this was done, or would you care one way or the other, based on what you've heard?
I have learned a ton today, and I promise I'm a researcher, but if it was my husband on the table, I would want to know what was best for my husband. As the wife having to make the medical decision. And I would defer to the professionals on what was going to save my husband versus necessarily what I've heard here today. What was the best choice for his particular case.
Yeah, that was a good diplomatic answer. But anyway, my argument with you is that for the cost, this
But I
device.
never brought up the cost. I
let
brought
me-
up expertise.
Let me. Okay.
Focus.
It doesn't
boss.
take any expertise. If a nurse can run 6 IMED pumps, she can squirt 20. A perfusionist or a nurse could squirt 20 cc's of saline into a stopcock. I mean, Dr. Samir, seriously. The point I'm trying to make here is that for the cost of one Protect Duo, one pays for that device. So it's not even a cost issue. We're talking about peanuts and very simplistic.
Can I answer that? Does the insurance pay for it?
No.
Okay. Thank you. Have a great day.
Okay.
So that's it.
That was easy. Okay,
That
so
was easy, yeah.
let's go around the table and wrap this up. Dr. Matoyer, any final thoughts for us here and the folks out there in Web World?
No, I look forward to going back and watching Tracy here and her vaping talk. As I see some of the effects now, I see a lot younger kids with issues, spontaneous pneumothoraces, and in addition to to add on to that, the normalization of use of marijuana in our culture. It's not benign. I mean, and I've got some great pictures that I can supply of what I thought I would never see in my time, which is basically looks like coal miners' lung, from doing these things. So it's a real public health issue, and it's I think it gets kind of put under swept under the rug. So, but the VV ECMO stuff, I mean, the Protec was interesting. I think it has a use, although limited. And I'm interested to work on the transonic bill. I think it's just going to add. I don't think it's going to be the end all be all. If I don't have it available one night, it's not going to really change a whole lot for me, but we'll see.
Very good. I don't know if you were here, but we have already talked to Tracy and Dr. Jothula and Dr. Samir and Tammy to do a part 2
Yes.
on this very topic. In fact, I want to do just the entire program on just this topic. I think that's going to be. In fact, hey, Magic.
Yes.
How many? What was our viewership?
Today,
Yeah,
1,300 about.
1,300. So we've touched 1,300 people with these discussions, and that's just till now. That's watching it now. As the days go on, that number just keeps growing. So I'm very pleased with that. Thank you. But we need to do that. So we're going around. So you're up.
Thank you, everybody, for having me here. It was a real honor for me to be here, and I'm glad that people found it informative, because that is my true passion, is if we can help one kid or one parent or one kid pass on something they didn't know to a friend who passes it on to a friend. That's my goal. That's been my passion since 1990. And everything that I've learned from the medical community as well about how much more often you guys are seeing it, it's a frightening topic. So thank you for having me.
Yeah, thank you. And I got to tell you, I think you deserve some serious compliments being up here with us. And we're going rattling off about, about hemorrhage and this and that. And, that's not what you do, but you stayed right in there and
Thank you.
contributed. But I think speaking for the whole group, I learned a tremendous amount from you. I learned
you.
a tremendous amount from everybody today,
Yes, I
actually.
have as well.
And we really appreciate and respect the fact that you may have learned some things
Oh, I
that
did.
you can take back, that we can help each other with our collective messages to the people as we need to. You from your arena and these folks and me from our
Absolutely.
arena. Dr. Samir?
I'll tell you, I'm really, this was a passion of mine to have this lecture, you know that, about the vaping.
Yes.
And really, I feel like we learned a lot from everyone here today. And I just want to, we should have a part 2, and we should keep an eye on Corona, because that is going to be another issue.
Another good point. Yeah, we saw it with H1N1.
Yes.
We had an ECMO outbreak from that pandemic, really. But we got through it, but it was tough. And we have that same, I think, risk that's right now stirring around
Yeah.
out there.
Yeah.
And it kind of scares me because resources are limited. But that's another topic that we can discuss. Dr. Jothula?
First I have to thank, actually, I learned a lot, to be honest. Yeah, we are physicians. At the end of the day, it's like boys playing with tools. We can talk about Avalon and Protect Duo and all the other things. But I think the biggest point is prevention. I think is a very key. As a parent myself, it's scary, to be honest, and it was very eye-opening for me. To how pervasive this problem is. I did not imagine that how common it is, and I don't know, is the normalization of the behavior. I think that's what we should come back. Actually, this is not normal. Yeah, kids are dying, literally.
Yes,
It's
they
something very serious we need to deal with.
They are dying.
And like you said, transplant is not a walk in the park. It is a whole lifestyle change.
Yeah.
Absolutely.
Oh, yeah, you have, your quality of life is, you're alive and probably grateful to be
It's a
alive.
different life,
But a
though.
double
Right,
lung
it's a very new
transplant
normal.
is
Yeah.
that's a
Exactly.
hard life.
Oh, yeah.
And I'm gonna ask you for a favor here in a second, so don't go anywhere, but Miss Tammy, you're next.
Just want to thank everyone for being here. I think this is an excellent, very timely talk. I think having the conversation, not just with the medical community, but getting information out there to the people that are our potential patients is the best way that we can try to make an impact. Preventative, I think, is what we really need to be doing, especially with this topic.
Okay, so I do have a favor to ask you, so don't go anywhere. Okay, so before I ask Dr. Jothula a favor, David, can you please put up the picture that I asked you to get? I received a text from Dr. Matoyer last night, and I'm not gonna read it. It wasn't.
I think you should read it. I want to.
No, I can't. I can't
better
read it.
not.
I can't read it. I can't read it. This was very personal. But anyway, so apparently he was not happy with his picture. Everybody else is happy and smiling except
Well, one of my
him.
biggest referring pulmonologists has already called me about
Yes.
that. Yeah.
So we have a camera. You're dressed real nice with the yellow tie and the blue suit shirt. You look really good. Your hair looks good. Like you mine too. I just came back from the salon yesterday.
Right.
And they were using a curling iron and they burned my forehead. I don't know if you noticed. But nevertheless, we could get another picture. But this is what happens when your perfusion team keeps begging you for a picture and you keep telling them that you'll get it, leave me alone, stop bugging me.
I've got
you'll
nobody
get
to
it.
blame but myself.
Exactly. So we have a camera. We're going to be able to take a picture. It's right there, and we're all set up and ready to go. Do you have a green screen that we can? Yeah, make sure we have a good picture of them. Make it a nice background. You know, like probably like a nice beach.
I was gonna
you
say a
know.
beach,
Yeah.
That's my favorite. Yeah.
Yeah.
Mine as well.
Yeah.
Yeah,
Mine
With
as
some
well.
Brazilians next door.
Oh,
But
now we're
that's
getting
another
into-
story.
No,
That's another story
like
altogether.
trouble.
Okay, so Dr. Jothula, the favor is, would you please, since you are into poetry and talking about
Oh, Lordy.
about looking at life from a positive viewpoint, I'd like if you so indulge us and give us your perspective and your thoughts on that, and maybe share some of that poetry with us.
Oh boy, that's a tough task. How did I start off with it? Obviously, at some point of time in the last 2 years, I've been on a very incredible personal journey myself, and I realized there is a big world outside the hospital, which includes rest of the common things which regular folks do. And I actually had the opportunity to meet some really good group of people, and they are the ones who actually got me into finding my own passions, clay shooting. So that was one of my biggest
Clay
things.
shooting, yes.
I like it. Yeah, poetry is something I always liked it. I don't know which one to talk about. There's one, I actually sent it recently. It's based on a patient experience. I'm just trying to find it on my thing, and I will share that one with you guys. But again, as you know, there is a lot of, I'm sure you're seeing it in looking into depression and anxiety, especially in the medical field. I have to tell you, I'm a South Indian. South Indian man, my dad has a mustache. It's a sign of masculinity. I've never seen him without a mustache. And that perception goes on into the house. I'm sure Samir can share the same things too. As men, you are expected to be strong and handle everything. It doesn't matter. And as we go along, I think in the United States at least a little bit less, but in India, it's still a very masculine culture. As a physician, you are treated as God, and that's how things are. So, I went to med school when I was 18. I don't think I saw much of a regular life. I didn't even know why I wanted to be a doctor, other than the fact the smartest kids become a physician. And to be honest, that's the reason I went into med school, because I was smart and I could get into the best one because I could really excel academically. And I really enjoyed being a physician actually after I graduated from med school. And life goes along. Obviously, as you can imagine, I'm an immigrant naturally. We all are coming from Indian subcontinent, very hyper competitive. So for me, it was going to a good residency program, getting into a fellowship at a great place, doing transplantation. I wanted to be a more immunologist because that's my passion, and going through it. But at some point of time, I hit a crisis in my life where I had to question, what am I doing? And when it starts, people can call it professional burnout, people can call it multiple different things and everything, but I was fortunate enough that finally I realized, you know what, strength does not come from ignoring your weaknesses. Strength actually comes from accepting it and seeking help. And that's how I went forward, and I was great actually. I was very fortunate. I found some support from my own university and a great group of friends, and I got into different groups. And one of the things we discovered was our shared passion for poetry. We started reading and writing, and that's where, after a really long time, I think after high school, I really started writing. And I'll share it. Maybe next time we'll do it. Actually, I can't find it right now. I just submitted it at.
Are you sure?
Oh boy. I'll show you. This is one of the ones which is very personal to me. I wrote it because at some point of time I really started feeling better about myself, and I wanted to talk about being a phoenix. It's very cliched, but let me tell you. And if you don't know, I have to tell you, I got a phoenix tattoo actually, because I thought it was literally something which I walked in my life and I found that I found myself back again. And let me read that for you. And any bad comments, please keep it to yourselves. I'm still, I wrote a lot, sorry. So this is the one actually. So essentially it's, who am I, what am I? I'm the proverbial phoenix, beaten, torn, and burnt, my soul and body in shreds, down to the last legs of my past, the future unknown. Welcome respite of the flames, burning the memories away. Look up, here I am, the phoenix rising from the ashes, flapping my wings, spreading them onto the expanse of the universe. Here I soar, soar high. Phoenix looking down from the sky. I am back with a new body, new soul, ready to conquer the world. And to be honest, I think one of the things that really helped me is looking at life as a perspective. It has given me a second life in my own professional career. I do enjoy being a doctor. I somewhere lost that passion, to be honest, in the middle. And that's something I highly recommend actually to residents and fellows. You need to have a wholesome life. One of the things people told me, it's like homeostasis. Like anything, as a physician, one of the things, one, you are a person. You have your family, your religion, your social belief, your social network, work on one aspect, personal passions, whatever it may be, and they all should balance out. That's how you'll, it's like essentially playing with a few balls and you're juggling it. And if you just stick to one, everything else falls down. I think that's what I realized. It's a whole other discussion, and that's one of the things I really want to write down the lane is bring more awareness about self-discovery, issues of burnout, depression and anxiety, the unknown or the hidden things which people don't want to talk about, which is very realistic, especially in medical field. And bring it more, and there's a huge stigma because that's something I thought about myself. That something was really, really, really wrong with me. And there's a huge stigma about it, and bring openness about it. We're all human at the end of the day. Physician is something which you do in your waking hours. The rest of the time, you're still a human. So that's something.
That's profound. No, I think that was very profound, and yeah, I think that's a whole nother topic because you have to be very stoic. You have to be very stoic. You have to be stoic. You have to be stoic. We're in there. These patients are, dying. We're around their families. You're doing everything you can. They can't see you emotionally affected by it. They can see a little bit, but you can't just really become emotionally distressed. They expect you to be professional, and I imagine you go home and that's really hard to do when you get home and your family member who's not in medicine cannot even begin to understand why you're so distant or unfocused or seemingly unhappy when you're really not unhappy. You're just sad.
Well, that's really what you're saying is, I'm Mark, but we identify ourselves as, I'm a heart surgeon.
There you go. Yep.
It's something we do, but we've been ingrained to identify ourselves as by what we do.
That's
Exactly.
right. That's right.
And that's
Exactly.
old school.
Absolutely.
I still do it.
I think the older,
But I tell people I'm a plumber.
Yeah, well, you are.
I am.
I'm
You
a
are.
plumber.
Yeah.
You're a flow assurance person. I'm a plumber. Okay, so yeah, so you got to think of it that way. But I think this transcends physicians. It transcends educators. It goes to nurses. It transcends nurses. It goes to, what do you do? Clinton?
Piping design.
Offshore piping design. One of your pipes failed. That's a big problem. I think that, yeah, it's a big problem. I think that all of us, I think that's where you were going, all of us as human beings, we want to be valued. We want to, we take pride in what we do. And when we fail, whether it be the patient didn't survive, even though it wasn't your fault or your fault, it was circumstances, you did all you could, you take it personally. Your pipe decides to burst and 10 people on the platform get killed. That ultimately falls back on you, and that fear is on your mind. The nurses in here taking care of the patient, whether it be hospice, I think one of you is a hospice nurse, the other one's an ICU nurse. Your patients are the hospice nurse, they see death every single day. And if they don't figure out a way to, I guess, compartmentalize it, it's going to have a profound impact on them. And even if they can do that, it's still going to have an impact on them.
Absolutely.
We call it PTSD when it's a soldier or a police officer or a fireman or something when it's acute. But these clinicians that take care of these patients 24, like you said, you see the patient 30 minutes, they're there 24/7, and they develop PT. I think that
Absolutely.
burnout is actually PTSD.
Absolutely.
Okay, the GoFundMe page, we want to do a program on just this.
Oh, that's a
because
great
of the
topic.
health of the healthcare professionals' mental
great.
health, or we'll figure out some way to say it
Caring-
so that
caring
everybody
for the
doesn't think we're
caregivers.
really crazy.
Lighting candles and
Yeah,
stuff.
and the other thing too is
That
he's,
affects your physical health too.
of course it does.
Yes, it does.
Of course it does.
Yeah.
And then that perpetuates more psychological troubles because your physical health declines, and so it's compounding, and then you get more physically unhealthy, and that keeps compounding, and it's like a vicious circle. But you are very humanistic, and I think it's important for people to see that.
Gotcha.
And
Thank
you've
you.
given me a renewed sense after having spent the day with Dr. Samir. You have given me a renewed sense on humanity.
And you just-
Truly, truly.
Thank you very much. I appreciate
Have
that.
you got the
Pincushion.
GoFundMe page up? There it is.
Thank you for doing that so much. His
Okay.
family's going to be.
Yes.
Yeah.
So please, I ask everybody who's watching to please, please, please go visit this page. Give $1,000, $100, $50, $1. Doesn't matter. Just go on the page and give something. I'm going to be doing that as soon as we're wrapped up here. So I'm challenging everybody and asking everybody to please donate to this kid. All right, and let's get the word out. So share it on Facebook, put it on the Twitter, LinkedIn, Instagram, YouTube, whatever else. All right, so let's help get the word out. Thank you all very much. We will see you next month. We have another program. I think we're talking about women in perfusion,
Women
the
in
challenges of that they have unique to men, and that's a program that Stephanie Ebus is putting together. And I think you're going to be you're off.
I
You're
will
going
not
to
be
be
here.
gone. You're not going to be here. So they'll dress me up like you, and I'll just be you for the program.
It'll be fun.
And
Oh.
That's a serious situation over here.
are the mics still live? Oh, darn it. Okay, now everybody knows. So we'll see you all the next program. Thank you all very much, and thank all of you for everything. I appreciate it. And so I think it's hamburger time. So thank you all. We'll see you next month. Look on the website, check it out. When the approval for the ABCP gets done, we'll get that up. Don't forget to be looking around for NurseWeb and NursePod and PerfPod and a whole bunch of different things. So we're really going to be making some major changes. So if you don't see a whole lot on the site right now, just keep checking because it's going to really blow up very soon. Thank you all. We'll see you later.
Mixed cannulae, expanding performance standards. High performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. Easy flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.